IMV Imaging, ultrasound designed by veterinarians for veterinarians. At IMV Imaging, we provide you with the best imaging equipment and technology, creating confidence in your clinical diagnosis. We don't just sell ultrasound. We build long-term relationships to support you clinically, technically, and with any other challenges that come your way. We understand in your career, you never stop learning. As a doctor of veterinary medicine, your career is enriched by education. With IMV Imaging, you can build on your knowledge with our online resources, which include webinars, case studies, quick guides, and so much more. All of our devices and products are advanced successfully by implementing ideas inspired by the needs of our customers, veterinarians. With over 35 years of experience in designing and manufacturing veterinary ultrasound equipment, IMV Imaging is dedicated to supporting you and your equipment. Most ultrasound scanners are sold through dealers or modified from a human scanner to suit veterinary needs. At IMV Imaging, we manufacture our scanners specifically for and sell directly to you to save you money without sacrificing quality or service.
Hello, my name is Audria Wood and I am the Media Specialist for the Texas Veterinary Medical Association. We are delighted you could join us for the first ever TVMA Everywhere virtual conference. This session is one of the featured presentations in our library of pre-recorded sessions. This video was recently filmed by Ken Yagi. Ken is being brought to you today by Veterinary Emergency Group. On March 10th, you should have received links to 4 on-demand pre-recorded sessions that include this session. Access to these sessions are available from now until June 14th. An additional 3 pre-recorded sessions will be added to the library after March 14th for a total of 7 pre-recorded sessions. These sessions represent a total of 18.5 CE credits. If you're interested in purchasing the digital conference proceedings, you can do so by logging onto the TVMA website at www.tvma.org and going to the online store. The cost for the manual is $15. Once purchased, it will appear in your digital library, and you'll be able to open it or download it from there. Start making plans now to attend the 2022 TVMA Annual Conference and Expo. We have hopes to have an in-person live event complete with incredible CE, fun social events, and a trade show. So mark your calendars for March 3 through 6 at the beautiful Kalahari Resort and Convention Center in Round Rock. This resort is home to the largest climate-controlled indoor water park in North America. Without further delay, I would like to introduce our speaker for today, Ken Yagi. During his 20 years in the field, Ken has discovered and refined his role as a veterinary technician by promoting compassionate and progressive care for the patients and their families. He obtained his VTS certification in emergency and critical care, as well as small animal internal medicine, and achieved his master's degree in veterinary science. He is currently the Chief Veterinary Nursing Officer for Veterinary Emergency Group and the Program Director for the Recover Initiative. He He has been awarded the NAVTA Veterinary Technician of the Year Award in 2016, the California Veterinary Medical Association Veterinary Technician of the Year Award in 2016, and the California RVT Association of the Year Award in 2017. Ken has also co-edited the Manual of Veterinary Transfusion Medicine and Blood Banking and has published various text chapters and articles in various publications. He gives presentations internationally on topics in ECC, transfusion, medicine, and the veterinary nursing profession. Ken works to encourage further recognition of the vital role of the veterinary nurses and technicians through work with organizations such as the National Association of Veterinary Technicians in America, co-chairing the Veterinary Nurse Initiative, and serving as a board member of the Veterinary Emergency and Critical Care Society, the Academy of Veterinary Emergency and Critical Care Technicians and Nurses, and the Veterinary Innovative Council. He is also an advocate for the open hospital concept, encouraging veterinary practices to invite the pet owners to the back as part of the team. Ken invites everyone to ask why, to understand the what and how of our field, and to continually pursue new limits as veterinary professionals and individuals. Everyone, Ken Yagi.
Hi everyone. My name is Ken Yagi, and I am a RVT from California, now residing in New York in Ithaca, working at Cornell University. I am also a veterinary technician specialist in emergency critical care and also small animal internal medicine, which ties me very close to some of the topics that we're going to be talking about today. I have other sorts of extracurricular activity that I do, which is a lot of the speaking that I do around the world now, which I'm very fortunate to be able to do. But also I'm the president of the National Association of Veterinary Technicians in America for 2020. And so we're all out there trying to advocate for the profession and making the profession better and better. So that's another thing that I do. But mostly I am very much a emergency and critical care nerd, much like you guys are probably. And so a lot of the topics that we'll talk about today hopefully will be useful to you.
Awesome, thank you.
All right. Anthony, do you think we're good to get going?
Yeah, let's get started.
Okay, sounds good. All right. So our first topic is going to be a little bit about shock, and then we're going to cover transfusion medicine afterwards, specifically focused on the emergency side of things. So the whole thing should take no longer than a couple of hours. 2.5 hours is what we allotted for ourselves today. And we'll have a 15-minute break in between the two topics so that you can take your bio breaks and things like that. So we'll just go ahead and get going. All right, so our first topic is about shock. And I'm sure you guys run into this all the time. But one of the things that I think about when we consider shock is thinking about asking this question to you guys. What are the types of shock out there? And I just want you to think about that for a second. And some terms may come up. And some of the terms that commonly come up are things like hypovolemic shock, when there's a loss of blood volume that's circulating within the body that causes shock. Maybe cardiogenic shock, where the heart's not functioning very well, and so there's a lack of forward flow of blood, which causes shock. Distributive shock, which relates to something called systemic vascular resistance, which we'll talk about in a little bit, but there's changes to the systemic vascular resistance that cause a lack of blood flow in the areas that need to be, and that causes shock. And there's also something called obstructive shock, that where major blood vessels are blocked, and then that causes shock. And these are terms that probably have come up in your head, and it's very commonly something that's responded as, or like the responses that I get when I ask that question. And so there's many different kinds of shock out there, and shock has many faces, and which is what I like to say. And so when we list those shocks out, hypovolemic, cardiogenic, distributive, and obstructive, I'm going to actually tell you that that's only one side of shock that we think about, the circulatory side. Now, there's the other side, which is hypoxemic shock, or things like hypoxemic shock when there's a issue with the respiratory system that prevents us from oxygenating our blood, or maybe there's a lack of hemoglobin, which carries oxygen, which gives us hypoxemic shock. There's also metabolic types of shock, which are things like hypoglycemia. We don't have sugar to create the energy with, or the metabolic demands are higher because of different situations that are going on in the body, or we could have mitochondrial dysfunction, meaning that we can't actually produce energy within our body, which causes shock as well. And so this is sort of the substrate-based side of shock. And so when we think about shock, we tend to think about the circulatory side mostly, but there's a lot of different types of shock out there. And we're going to focus on the circulatory side of shock today, though. So what is shock? If I was to ask you what the fundamental definition of shock is, how would you answer that? Hopefully, what you've come to is this right here, ATP, or adenosine triphosphate, something that we don't really tend to think about, or maybe we've tried to block out of our minds. But the main point is that ATP is something that the body needs. It requires oxygen for it to be created through this process over here, where we take a molecule of glucose that is cleaved into substrates, and one of them is pyruvate that is carried into the mitochondria that goes through the citric acid cycle and then the electron transport chain going through oxidative phosphorylation, all these fancy terms that probably don't want to even remember anymore. But going through that process, which is called aerobic respiration, is how we create much more ATP than we can without having oxygen present. And when the body's unable to produce enough ATP to meet the demands of the body in terms of energy, that's when we fall into shock. So the fundamental definition of shock is we are in a state where we are unable to produce enough ATP to sustain life processes. And so ATP, if you recall from your biology class, is important for so many different things out there that the body does. This isn't even an exhaustive list, that it's very important for us to be able to create that. And we need oxygen in order to do so. And if we were to take a look at the amount of oxygen that the body receives, the tissues receive, then we can turn it into a equation that looks like this. I know it's a little bit intimidating. It's something that we memorized as people going through the VTS process and trying to achieve our VTS certification. But conceptually, it's actually pretty simple. All we're trying to say is that delivery of oxygen, which is how much oxygen the tissues receive, is a function of arterial oxygen content, how much oxygen is actually in your blood, and cardiac output, how quickly the body or the heart is circulating that blood that has oxygen in it to carry it to the tissues, which leads to that delivery of oxygen. And so those are the two key pieces that we're talking about. Now, this side, the arterial oxygen content side, which is all the red stuff that's on the screen right now, it can be broken down into the level of hemoglobin that the animal has, how well the animal can saturate that hemoglobin with oxygen. And there's a little bit of oxygen that gets dissolved in the plasma as well. But that's one side of delivery of oxygen. And so this arterial oxygen content can be influenced by things like red blood cell loss, that we have animals that bleed for whatever reason and they lose their hemoglobin level. And that's what leads to a loss of oxygenation and delivery of oxygen. It could be that there's different kinds of reasons why red blood cells are destroyed and they don't have enough hemoglobin because of that reason. Or maybe it's kidney disease or other reasons why red blood cells are not produced to a sufficient level that the loss exceeds the production of red blood cells, which lead to a reduction of hemoglobin. That's one way that this side over here, hemoglobin level, could be reduced such that the arterial oxygen level gets reduced as well. Now, we also have to consider respiratory compromise. You have a patient that has congestive heart failure, that has pulmonary edema and is unable to breathe very well. or maybe it's a pleural space disease like pyothorax that you probably have seen many of. That leads to the animal being unable to breathe as well as they should be able to, which leads to a lack of saturation of hemoglobin. And that's another reason why delivery of oxygen could suffer. And so for delivery of oxygen to be normal for these patients, two key pieces need to be normal. One is proper hemodynamic status, and that cardiovascular system is functioning properly and we're perfusing the tissues with blood well. And then the other side is the arterial oxygen content, how much oxygen we can actually carry in the blood that we're circulating as the heart pumps and pushes blood through the blood vessels. And so now we're really going to start focusing on this side over here, proper hemodynamic status. How do we maintain that? So again, when we take a look at that equation, DO2, or delivery of oxygen, was a function of cardiac output and arterial oxygen content. We broke down the arterial oxygen content just over the past few minutes, but now we're going to break down cardiac output. Cardiac output can also be broken down into several factors that come into play. One is stroke volume, how much blood is coming out of the heart per stroke or per contraction that is going on, and the heart rate, how often that stroke is happening, that contraction is happening. Which kind of makes sense, right? That it's the amount of blood that's coming out of the heart and how often the heart is pumping. When we take a look at stroke volume, we can break that down into three different factors as well. It's actually four different, but we lump it into three. One of them is called the preload. How much blood is coming back into the heart that the heart is going to be able to push out. The next one is called afterload. The pressure that the heart has to push against in order to get the blood out of the heart. And then contractility, which is how hard the heart can actually push in order to overcome that pressure that we just talked about. These three things need to be normal in order for us to be able to push blood out in a sufficient manner that creates a good stroke volume, which contributes to good cardiac output. And then it's this cardiac output, how much blood is coming out of the heart, that meets something called systemic vascular resistance, which is the amount of resistance that the blood vessels exert against the liquid that is being pushed out of the heart in order to create something called blood pressure. And that's what we measure, is that we're out there measuring blood pressure, hoping that it leads to good perfusion. If you have good blood pressure, then we should have good perfusion. Now, if we think about cardiac output as sort of your faucet or spigot that you have, then if you open and close, open and close, open and close that faucet, then you can think of that as the cardiac output. The heart is pumping, and each time it pumps, it's as though you're opening that faucet. The systemic vascular resistance is something provided by something like a hose that's attached to that faucet. And so if you attach a hose onto a spigot over here, and then let's just imagine that you wanted to wash down the wall in front of you that you are facing, just by laying and pointing the opening of the hose at the wall, would it actually get there? It probably wouldn't, right? Or it would take a long time for it to flood that area, and then it gets to the wall or something like that. But is there something that we can do to the hose itself in order to allow that fluid to reach the walls much sooner? And you're probably thinking something like, well, you could put your thumb over it. Yeah, exactly. You can put your thumb over it. It increases the pressure in which the fluid comes out of that hose, and then you're able to reach farther and with a larger amount of pressure. And that's because you are pushing your thumb over the opening, which narrows the opening, which increases the pressure because you've just increased that resistance. And that's how blood vessels work as well. Think of the blood vessels as being these hoses, but hoses that can either constrict to become narrower or dilate in order to become larger to control the pressure in which the fluid is moving through it in order to get to the tissues that we need to get it out to. And so that's how the body normally works. It can manipulate the cardiac output or systemic vascular resistance in order to maintain normal blood pressure so that we have perfusion, which leads to delivery of oxygen. And this concept is going to be important as we talk about different kinds of shock throughout this talk. So let's consider something like hypovolemic shock. Hypovolemic shock is a situation where the animal could be maybe gotten into the Memorial Day weekend barbecue trash and comes in with severe pancreatitis and starts vomiting up liquid and can't keep water down or anything like that. Or maybe it's an animal that's having severe liquid hemorrhagic diarrhea where they're losing fluid as they are having bowel movements. Or it's an animal that has a splenic mass that has ruptured and is losing blood volume very quickly. Or it could be something like an animal that's sustaining polyuria and is losing liquid out of its urine. Whatever the reason is, there's a loss of intravascular volume. Because of that loss of intravascular volume, there's a lack of preload, the amount of blood coming back into the heart. And so you can see that as the animal loses intravascular volume, the preload will go down, which will then affect the stroke volume, which then affects the cardiac output. And so then you would think that it would affect the delivery of oxygen as well. But what the body does is that it'll compensate a little bit. It'll compensate by, say, increasing the heart rate so that the cardiac output remains normal, which then sustains normal delivery of oxygen. But if we can't help the animal from losing more blood and intravascular volume suffers further, then no amount of compensation is going to compensate enough to maintain good delivery of oxygen, which then ultimately reduces the delivery of oxygen, which leads to hypoxia for the tissues. If we think about something like cardiogenic shock, it's a little bit different in that there could be dilated cardiomyopathy where the walls are pushed out, thinned out so that it's weakened and it's unable to create enough forward flow. It could be something like hypertrophic cardiomyopathy, which cats get more than dogs, where the walls thicken. So you can see that the chambers of the heart is smaller. And so there's loss of the amount of blood that can be contained in the heart to push out. Or it could be something like this. This is an image of a echocardiogram that is showing that there's actually between the wall of the heart muscle that I'm tracing right here. And I just want to make sure you guys can see my mouse pointer. And then over here is the white line that we're seeing towards the bottom of the image is the pericardium that has detached from the wall because there's this black area in between that represents fluid. And so now there's fluid accumulating from within the pericardium but outside the heart muscle wall, which then pressurizes and pushes down on the heart muscles so that it prevents the heart from actually being able to fill with blood because it's being squeezed from the outside. And then you may have a patient that is experiencing something like ventricular tachycardia, where the heart is beating so fast and so quickly that it's not allowing blood, not allowing enough time for blood to come and fill the chamber of the heart in order to squeeze out and create good stroke volume. So whatever the reason is, there's different kinds of cardiac diseases and conditions out there that you can, the animal can sustain, but it fits into one of the following. It's one, either that it reduces ventricular filling, meaning that there's less blood filling the heart, or there's myocardial dysfunction, that the function of the heart in terms of its ability to beat and create good contractility is compromised. And so whichever side it is, it still affects stroke volume, which then leads to a reduction of cardiac output, which again, the body will try to compensate for a little while, but as it gets worse and worse, it's not going to be able to compensate well enough, and then it leads to a reduction of delivery of oxygen and shock. Now, distributive shock is a little bit different. If you think about this diagram as those two cats being the heart and the red stuff being the blood vessels that's circulating around the body, the blood stream will go to vital organs like the brain, liver, digestive system, things like that, or non-vital organs like the extremities, the paw, the ear, the tails, things like that, where intentionally already in a normal situation, more blood flow is going to the vital organs as compared to the non-vital organs. And that's how the body works, and the heart will pump to circulate blood in this system. Now, what happens with distributed shock is that there's some kind of a insult, something that shocks this system, which then changes the distribution of blood, where normally more blood would be going to the vital organs. It shifts it in such a way that it pools in locations that it doesn't need to be, taking blood flow away from the vital organs. And so what causes that? There's different kinds of reasons that can, different causes out there for it, but it all relates to usually systemic inflammatory mediators. Systemic inflammatory mediators, these are cytokines, things like that, that will circulate when there's severe inflammation going on that causes dilation of these blood vessels. And that's why it's called vasodilatory shock. It also causes something called relative hypovolemia. That if you can imagine a cup of water that you have that is filled to the top. The cup has a finite volume. There's a certain amount of water that is in it. Think of that as the blood vessel and the blood that is contained within the blood vessels. And just imagine all of a sudden the diameter of that cup getting much larger, that the narrow cup has turned into a big, bucket almost. Even if you have the normal amount of blood within the volume that's contained in this small cup, when you increase the diameter to a larger cup where you dilate those vessels, the normal amount of blood flow is considered hypovolemic, meaning that it's less volume than you need in order to maintain good blood pressure. And so it causes a relative hypovolemic situation. Now, examples of causes for this could be something like anaphylaxis. There's a mast cell degranulation that releases a bunch of inflammatory mediators in circulation, which causes vasodilation. There are many different kinds of severe inflammatory diseases that could cause this, and you probably have heard of systemic inflammatory response syndrome being one of the conditions that animals could be in that is related to distributive shock. And sepsis is another one. Sepsis is just systemic inflammation that's caused by an infectious origin. And so those are some of the common examples that you may see in the emergency and critical care situation. All right, so those were the types of shocks. And how do you assess shock? You can clearly see that this cat is in shock. But what about this dog? Is this dog in shock? What's going on with it? Is it just sleeping? Is it sedated? Is it coming out of anesthesia? It's hard to tell, isn't it? Just by taking a look at a photo. And so this is where something called perfusion assessment comes in. These are physical parameters that you can monitor in order to determine whether the patient's perfusion is normal or not. And so those are things like heart rate, pulse quality, mucous membrane color, capillary refill time, the extremity temperature compared to the core body temperature, and mentation or alertness. And so we're going to take a look at how shock changes each of these elements, and that's and how it relates to your assessment of an animal in shock. But we first have to talk about blood pressure regulation. And I promise this is the most dullest part of this talk, I would say, that we have to get over. And then we're going to start talking about cases. So hang in there. So blood pressure regulation is something that is actually governed by something called baroreceptors that reside in the descending aorta, mostly in blood vessels, and they respond to stretch. When they're stretched out, they are stimulated, and when they are less stretched out, then their stimulation goes away. So let's just say that you have an animal and you bolus a bunch of fluids into that patient, which then obviously stretches the blood vessels out. What would happen in that situation is that the baroreceptors are stimulated, going through the vagus nerve. This green line that you see here stimulates the cardioregulatory and vasomotor centers that's in the brainstem itself, and it has several effects. And when we start talking about parasympathetic, sympathetic, I think start to lose people, so I'm not going to go into it in too much detail, and that's not the part that you necessarily need to memorize. But we just want to know that this increase in stimulation of the cardioregulatory and vasomotor centers will cause two different effects. On the heart, it will decrease the heart rate and decrease the stroke volume. In the blood vessels, it causes vasodilation. And so blood pressure should return to normal. So we're reducing cardiac output and reducing systemic vascular resistance, which lowers the blood pressure, which would make sense if you accidentally bolused an animal. Now, in shock, the opposite is true, in that there's a loss of stretch because there's some kind of loss of intravascular volume, for example, that reduces the amount of stretching that these baroreceptors are experiencing, which then leads to a reduction of stimulus of the brainstem, the cardioregulatory and vasomotor centers, which then has the opposite effect on the heart and the blood vessels. It leads to increase in heart rate and stroke volume, which increases cardiac output, and a vasoconstrictive effect, which narrows the blood vessels, which increases systemic vascular resistance. So with an increase in cardiac output and an increase in systemic vascular resistance, the blood pressure goes up and returns to normal, hopefully. And I say hopefully because there are sometimes that this compensation isn't enough to keep the perfusion normal. So an animal that is experiencing shock, as we assess them, we could categorize them into 3 different stages of shock. The first one is called the compensatory stage. This is when there's probably peripheral vasoconstriction that's going on. The blood is shunted towards the core of the body. It allows the animal to compensate for the loss of normal perfusion by making these changes: increase in heart rate, increase in stroke volume, and vasoconstriction by the mechanisms that we just talked about. So how does that relate to signs on the animal? Well, increase in heart rate is tachycardia. Increase in stroke volume will present as bounding pulses, in that each stroke, each contraction of the heart is going to be creating more blood flow out of the heart, so it turns into a bigger bounding pulse. The animal could be pale or have normal mucous membrane color. And this one, have to think about the blood vessels that are in the tissues that we're looking at. So if you're taking a look at the gum color of the patient and the snout being considered the periphery of the body, there's vasoconstriction that's going on. The blood vessels in that area is much, much narrower, which means that there's less red blood cells flowing through the tissues itself, which then makes it less of a red color, turning it into a pale color. The capillary refill time could be slowed down as well, in that when you have that constricted blood vessel and you push down on it to collapse it, which is what we're doing when we check for CRT, is that when you let up on that pressure, it takes a little bit more time before the pressure gets accumulated to the point that those clenched down blood vessels can be opened back up again in order to have red blood cells flowing through it, which shows that pink color. And so because of that, the capillary refill time could be slowed. Blood pressure is probably going to be reading normal because the body is compensating well enough for this situation. And that's actually the definition for compensatory stage of shock, is that the body is compensating well enough. And so the blood pressure wouldn't have been suffering. Maybe it would be slightly increased than normal because the body has a tendency to overcompensate. The animal probably will have cool extremities because there's peripheral vasoconstriction going on. The heat exchange normally occurs with the blood flow coming from the core to the extremity. So if there's constricted vessels in the periphery, there's less blood flow going to it, so less heat exchange. And we also will see a normal mentation, or the animal should be alert. And these are the dogs that come in hit by a car, maybe got grazed, and they're jumping around and overly excited in the room. Now, cats are a little bit different in that they may not present tachycardic, but they may present bradycardic in this situation. So take a look at those gums, and those are the types of things, the 6 different parameters that we should be looking at in order to assess a patient in shock. Now, this mentation is interesting. Take a look at this animal and let me know what you think about its alertness. And mentation itself can be categorized into 4 different categories. One is alert or normal, which is all of us right now, hopefully. Dull or obtunded, which is a person or an animal that needs some kind of stimulus, auditory, visual, something that catches our attention, which brings our alertness back. But when those stimuli are not present, we would not be alert, and so dulled in alertness. Stuporous is when you need a noxious stimulus or painful stimulus, whether it's sharp objects, being poked at you, high heat, source of heat, so like something that's really hot, noxious smells, chemical stimuli, things like that, that will bring back alertness. And comatose is when none of that makes a difference, that any kind of stimulus will not lead to regaining of consciousness or alertness. And so here's a dog that has congestive heart failure, has pulmonary edema, which means that there's a lack of blood flow and oxygen content of the blood. You can see that this animal is likely in that stuporous state, not quite comatose, but stuporous, probably, at least old and obtunded. And this all has to do with, at least on the circulatory side, with something called cerebral perfusion pressure. Now, cerebral perfusion pressure is the difference between mean arterial pressure and intracranial pressure, in that if you think about the amount of blood that's going to be flowing to the brain itself, there has to be enough arterial pressure, blood pressure, in order to push against the pressure that's already present in the cranium, which is intracranial pressure, in order to overcome it. So if you can just imagine something like hypovolemic shock, where the animal loses intravascular volume, which reduces the mean arterial pressure, it will eventually get to the point where the mean arterial pressure is low enough that it won't overcome the intracranial pressure in order to bring blood flow and oxygen to the brain. And so as cerebral perfusion pressure is higher, then the animal would be more alert and normal. Whereas if the the cerebral perfusion pressure goes down, then you'll go down the scale to become dull and obtunded, stuporous, and comatose. Yeah, Alex, I agree that this dog looks horrible. So the question that the body's really trying to answer is my brain getting oxygen? So that was compensatory stage. Decompensatory stage is when the animal is likely shunting more blood flow to the core of the body towards the brain and the heart. Some of the vital organs that is still considered peripheral to the real core, which is the heart, lungs, and brain, they become ischemic because there's so much peripheral vasoconstriction going on, and there's a lack of perfusion that is present. And so these are kidneys, the GI tract, things of that nature. The animal will exhibit metabolic acidosis because there's a lot of anaerobic metabolism going on. And the signs that you see here are still going to be tachycardia. The body's trying to compensate as best as possible. Tachypnea at this point, because a lot of the tissues within the body are not receiving oxygen. And so the body's trying to get more oxygen into the bloodstream as possible, which then leads to tachypnea or even deeper breaths that the animal is taking. It could be compensatory to the metabolic acidosis, which is a factor to consider as well. At this point, the animal would have weak pulses in that there's not enough blood flow being generated by the heart itself, that the pulses would be weak. There would be pale mucous membrane, definitely at this point, that it would not look pink at all because there's severe vasoconstriction going on. The capillary refill time will be prolonged, likely to a severe degree. And then here's the more of the defining factors of decompensatory stage shock, is that the blood pressure will now read low because the body's not able to compensate to keep the blood pressure normal. The extremities definitely would be cold, even rectal temperature may be cold, because if you think about the rectum, relatively speaking, it's considered a peripheral part of the body compared to the rest of the core. And then also another defining characteristic is that the animal would now be obtunded in mentation at the least, meaning that they won't be alert, because if they were alert, then they would be, by definition, compensating well enough that there's enough blood flow going to the brain. When we think about some of the blood work that we can run in this situation, an elevated lactate is something that you would tend to see. And so that brings us to the point of lactate. Hopefully, many of you guys out there do have a lactate meter available for your emergency practices, because that would be definitely important. And those of you who have experience with it are looking at this number, 14.3, and cringing quite badly because it's extremely high. This lactate can serve as a marker for anaerobic metabolism. When we took a look at that diagram of the mitochondria very early in this presentation, probably saw that there was pyruvate being created. Pyruvate, if it doesn't go anywhere else, will then get metabolized and turn into lactate. It's normally cleared by the liver, and so in a normal situation, it's kept below 2.5 millimoles per liter in the amount that's floating around in our serum or in our blood, plasma, I should say. It can serve as, when it's elevated, it serves as a sign of significantly reduced perfusion. Anything greater than 5 millimoles per liter is said to contribute to acidosis, and that's where that term lactic acidosis would come into play. So let's just say that we can't help this animal even through the decompensatory stage, and they go further into shock. They'll eventually reach a stage called terminal decompensatory stage of shock. And this is when compensation is already exhausted, the heart and brain is becoming hypoxic, and so you start seeing signs of all that. There definitely would be severe acidosis because there's a lot of lactate production going on. Because the heart and brain is hypoxic, there's going to be a loss of cardiovascular function. So, and it'll lead to multiple organ dysfunction, and this is when the animal is about to die. What are the signs that you'll see during this stage? It'll be bradycardia because the heart's not even receiving enough energy, enough oxygen to create the energy that it needs to keep going. You likely will not be able to feel a pulse. You won't be able to read any blood pressures. You might not have any kind of mucous membrane color, or it could be white because there's so much peripheral vasoconstriction going on. Or at times, at this point, it might pink up a little bit because the vasoconstrictive effect is being exhausted as well. And so it'll the capillary refill time will depend on which aspect that you're seeing there. And in terms of the mentation, the animal would be stuporous to comatose. So we kind of covered the types of shock that could be out there, at least circulatory related, and also the stages of shock and how they might look in those stages. And so now I want to turn it over to you guys and have you take a look at this patient. This is Rusty, a 4-month-old mixed breed dog. And the history is that he has been vomiting, having diarrhea for the past 3 days or so, and that's when he's brought in. Upon presentation, his heart rate is 196, pulses feel weak, respiratory rate is 36, breathing with abdominal effort. Mucous membrane color is pale, capillary refill time is 3 seconds, temperature is 96.1 degrees Fahrenheit or 35.6 degrees Celsius. And the extremity is cold to touch. Blood pressure is 68 millimeters of mercury at systolic with a Doppler. And the mentation level is obtunded in alertness. So the question that I will first ask is Rusty in shock? And if so, what stage? Give you guys a second to think about that. Great. I'm seeing some yeses, which is good. Yes, definitely in shock. What stage of shock? Decompensatory. Yep, I would agree with that. I would say decompensatory. And a lot of this over here, like tachycardia, the paleness, CRT being prolonged, temperature being lower, some of that could happen with compensatory shock. But with that said, especially when the temperature starts to get affected, the blood pressure is lower than normal, and the mentation is obtunded, these are probably defining factors where we would say this animal is already in decompensatory shock and not compensating well enough for itself. Okay, so what type of shock is this patient in? Those of you guys who guessed hypovolemic, that probably is what we would think about. Great, thanks guys. Because just taking a look at the history, that's what we would assume in this situation. There's different things that we can take a look at to confirm that. If the heart auscultation doesn't show any kind of murmurs, there's no pulmonary edema going on, those kinds of things will point it more towards a purely hypovolemic situation rather than any kind of cardiogenic issues going on at the same time. All right, so then the question is, what do we do now? And that's where we shift over to thinking about what can we do for the patient in the immediate situation, which leads to something like emergency stabilization. And you probably are thinking we would give it IV fluids, which definitely is true. I just want to back you guys up one step and say, what about oxygen? Would oxygen be helpful in this situation? And the answer is yes, it will. In that even though oxygen is not going to be the key factor for a patient that's hypovolemic in order to regain a normal level of oxygen delivery or DO2, it's still going to put more oxygen into the bloodstream, which will maximize the delivery of oxygen. And so being able to put on some kind of non-invasive form of oxygen supplementation, whether it's flow by oxygen or mask, would be helpful in that particular situation. But you guys are also right that fluid resuscitation is what the animal really needs. And I'll just preface it by saying this is for all but cardiogenic shock patients, because if you have a cardiogenic patient that has cardiogenic shock, depending on the reason why that's occurring, more fluids could be harmful for the patient. But with that said, venous access, whether it's a peripheral IV catheter, jugular IV catheter, intraosseous catheter, if it's an animal that's small enough that you can't get a catheter in, intravenous catheter in very quickly, we would provide that, and we would start out by using crystalloid fluids. And so we would replace intravascular volume that the patient has lost. But the tricky thing about crystalloids is that we know that even though we provide that intravascular volume, crystalloids are fluids that will quickly redistribute within the body, that only about 25% of it remain within the blood vessels after 30 minutes. And so we do need to continue giving maintenance doses or maybe further doses of boluses. There is a question that's being asked, would you use nasal cannulas to provide that oxygen? In that emergency stabilization situation, we probably wouldn't go as far as providing nasal oxygen because that does cause a little bit more stress. It's a little bit more, I would say, permanent form of providing oxygen on an ongoing basis as the patient is hospitalized, for example. So if the real issue is that the patient is hypovolemic, providing that fluid bolus is going to be a larger factor in helping the patient regain delivery of oxygen. And so we would think about stabilizing the patient in the intravascular volume sense before we go further with the oxygen supplementation. If the patient has primary respiratory disease, that may be necessary in order to provide more oxygen supplementation, but that's on a case-by-case basis. So the flow by and mask is probably a quick thing that you can do while you're correcting the hypovolemia. All right, so when we think about shock dose of crystalloids, these numbers probably come to mind, something like 90 mils per kilogram for dogs, 45 mils, maybe even 60 mils per kilogram for cats. Now, I'm going to say no. Grumpy Cat says no. May he rest in peace. That the updated approach is actually more along the lines of giving something like 20 to 30 mils per kilogram for dogs, 10 to 20 mils per kilogram for cats, over a course of about 15 minutes or so, and then reassessing the patient to see if they need more fluids. And the reason why we do this is twofold. One is that the 90 mils per kilogram for dogs, for example, is the total estimated volume of a dog right there. And so if you have a patient that is in hypovolemic shock because it's lost a percentage of its blood volume, and you just slam in a full blood volume of a dog, then you can easily overload the blood vessels or the circulatory system, which then leads to negative effects as well. The other point is that we are more aware of things like the glycocalyx, which is a protective layer that's within the endothelium of blood vessels. And we don't need to get into this too deeply because it's another hour or two of discussion that we could have surrounding this. But by providing huge boluses, we are being unkind to this protective layer that the blood vessels naturally have. And so providing a more gradual fluid dosing is going to be better for the patient in the long run. And so the conclusion comes to, we take a more conservative approach in fluid therapy, where we give a smaller amount of volume over a course of time, and then we reassess the patient. And so the goal is to have the perfusion parameters be more normal, the mean arterial pressure to be greater than 80 millimeters of mercury, and that would be pretty normal. Now, there is something called hypotensive resuscitation as well. And so this is a situation where we actually want to maintain a lower mean arterial pressure than what's considered optimal, or the 80 millimeters of mercury that we just talked about. And these are situations like patients that have trauma with cavity hemorrhage, meaning that there has been a traumatic event. The body's trying to clot up all the blood vessel damage that has occurred. And as the body's trying to do that, you slam in a bolus, and it increases the blood pressure quite a bit, and it blows off those blood clots, and it creates more hemorrhaging to occur, causes more hemorrhaging to occur. That's not a good situation. So you keep the blood pressure a little bit low. It may be a patient that is experiencing brain edema. And so if you suddenly increase the amount of fluids that are circulating, the blood volume that's circulating within the blood vessels, it expands the blood vessels within the intracranium, which adds to that volume and space being taken up by that expanded blood vessel, which will increase the pressure within the intracranial space. That leads to more physical damage to the brain cells, which leads to further brain damage. And so for animals with head trauma, you may want to reduce the amount of pressure that we're providing in that brain or in that intracranium. Animals that already have pulmonary edema, if you give too much fluids and increase the hydrostatic pressure within the blood vessels, then there will be more leaking into the lungs that happen as well. And so those are a few examples of situations where hypotensive resuscitation may be more recommended. And the goal in this situation is to definitely still improve the perfusion parameters, but keep the mean arterial pressure around 60 millimeters of mercury, so that we're not causing these negative effects excessively. We talked about crystalloids. There's also something called colloids, which are fluids that contain these larger molecules. You can see to the left side of this the gray barrier that you see on the screen. And that pulls more water towards the side that has the larger molecules by causing osmosis. And so it increases something called colloid osmotic pressure. It's tool that we have available to us that allows us to keep more of the fluid within the space that we want it to, which is in the blood vessels. And when it's given, it's often given with crystalloids itself. Now, we do have natural colloids within our body, which is called albumin, which creates colloid osmotic pressure. It is something that is contained in plasma, and so it can be given, plasma can be given to try to increase the amount of albumin within the blood stream, which is not recommended. We'll talk about it a little bit in the transfusion talk. And there's also something called albumin concentrate that is available as well. Albumin concentrate, probably have seen human albumin concentrate because that's more available and accessible to us. The disadvantages of human albumin concentrate is that it is immunogenic in that it can cause allergic reactions for our animals. It's also, relatively speaking, expensive. Now, there is canine serum albumin products out there as well that is known to not cause the degree of immunologic complications that human serum albumin does for our patients. But at the same time, the supply may not be as available around the nation and the world. And so it is something that may be a little bit harder to get our hands on. So I would just look at our options. Now, obviously, there's synthetic colloids like vet starch or head starch or whatever solutions that you guys may have, which is a solution of hydroxyethyl starch, which has the advantage of it being inexpensive. It's not immunogenic. It doesn't cause allergic reactions in the way that human serum albumin does. You don't need as much of a volume as plasma to try to increase the colloid osmotic pressure. But it also has its disadvantages in that it can cause coagulopathy by interfering with coagulation when given at a higher dose. And we also know that, at least in people, there's good evidence to show that it leads to kidney injury, especially in patients that are either having a severe or chronic inflammatory condition. And many of our critical care patients fit into that category. And so we are altogether questioning how much synthetic colloids we actually should be using in critical care. And so you'll probably see people who have moved away from it quite a bit. So with all that said, we gave that fluid resuscitation in however strategy that we chose. And this is how our patient looks. Is our patient better? I would say so. Heart rate is relatively back to normal for a small animal like this. Respiratory rate has come down. Mucous membrane color is pink. CRT is within normal range. Temperature has come up. And the blood pressure and mentation has changed. And so, yes, we're happy about that. So then we have to think about what's the next step. And the next step is just to treat the underlying disease. And so this is a little Chihuahua mix that had come in because of parvo. And so what do? Well, you can see that the patient has a nasal enteral tube. That's one of the key things that we recommend with GI issues these days is enteral feeding, plus continued fluid therapy, likely antibiotics. And those are the kinds of things that we would be thinking about. And so the emergency stabilization part is there that we can institute. And then we have to think about, okay, how do we get this fixed long term? Now, I'll talk a little bit about cardiogenic shock in that we said fluid resuscitation is likely needed for all but cardiogenic. And the reason why we say that is because when the patient has cardiac diseases that causes cardiogenic shock, then there are different reasons why sorry, I got distracted by the video there. Just going to restart and say that we want to optimize preload. And preload, if you remember, is the amount of blood that fills the heart so that it can be pushed out. And so that may come from doing things like monitoring CVP, which is central venous pressure, which is kind of falling out of favor at the moment. Not many people measure it anymore, which I think is which I think is the trend at the moment. But if you do measure CVP, then you can use that as a guide for fluid balance, as long as you know that that number can be trusted. There's no other things that are influencing it, like intra-abdominal pressure that's going on. Any kind of mechanical ventilation definitely would make it harder for us to interpret that. And so there's various reasons why we don't trust CVP very much anymore, but that's one way that we had been doing that. The other thing is if it was something like pericardial effusion like we talked about, then pericardial synthesis to remove the pressure around the heart is going to be needed. There are measures that we can use to reduce afterload, such as antihypertensives that are either nitrogen compounds, they may be angiotensin converting enzyme inhibitors. These are things that we cause vasodilation with so that the afterload is reduced, the pressure that the heart has to push against. And then we also want to help the patient to have increased contractility by providing things like inotropes, which are medication that will help the heart contract better. And so all this is to try to improve forward flow. All right, so we're going to finish up with this particular case this is copper. Oh, and before I show you all of this, I would just preface it and say that copper is a patient that came in a few years ago, vomiting, and with the diagnostics that were performed, radiographs and ultrasound, abdominal ultrasound, it was likely that the patient had a GI foreign body. So copper was taken into exploratory surgery. We did indeed find that there was a foreign body that was lodged in the small intestines. And so a resection and anastomosis procedure was performed where that foreign body was removed. And copper went home, hospitalized for a little while afterwards, went home just fine. Now, she came back and showed the same kinds of signs, that this was incessant vomiting that was going on, and had similar signs. And so it was thought that she had a foreign body, went into exploratory surgery. Sure enough, there was another obstruction. It wasn't necessarily like a foreign body ingestion related obstruction, but it was adhesions that were created and stricturing of the intestines from the previous surgery that created a narrowing of the intestines, and this glob of grass and hair and gunk got lodged and created a obstruction. So that part was resected, and another anastomosis was performed, and the copper was recovering in the ICU, and that's where we pick up. This is how she looks. So surgery was performed 4 days ago. She was hospitalized after that surgery. And then she was showing some abdominal effusion. When abdominal centesis was performed, it was seen to be septic. The patient is hypoalbuminemic. There's pulmonary edema going on. Maybe even possible pneumonia. Maybe she had aspirated while she had been vomiting, and the patient is now hypotensive. Heart rate is 112, pulses are weak, respiratory rate is 40, respiratory effort shows abdominal effort, mucous membrane color is red, CRT is less than 1 second, it's rapid, and temperature is 103.2 or 39.6 degrees Celsius. Mentation is obtunded, blood pressure is 70 millimeters of mercury. Fun. So I'll just skip the question of, is this patient in shock? Yes, this patient's in shock. What kind of shock? What type of shock are we looking at? So I want you to think about that a second. And so I will go ahead and say that there's probably not just one type of shock that's going on in this patient. There's contributing types of shock. And one of the ones that you probably thought of immediately is that this is probably distributive shock because of the red mucous membrane color, the septic abdominal fluid. This animal is probably going septic, is what many of you are probably thinking. And so, yeah, you're right, that this patient's probably experiencing distributive shock. There's inappropriate vasomotor tone because of sepsis that's going on. This patient is probably experiencing hypovolemic shock as well, that there is hypoalbuminemia, which means that there's a lower colloidal osmotic pressure, there's fluid leaking out into tissues and not staying within the blood vessels. That's probably why you're seeing pulmonary edema and abdominal effusion. And so there's a loss of intravascular blood volume into the abdomen and the pulmonary parenchyma as well, which then I could say that probably leads to the animal having a aspect of hypoxemic shock as well, meaning that there's probably less oxygen being taken into the bloodstream. And there's a question of whether there's cardiogenic shock going on as well, that the heart rate of 112, when this patient should be compensating very strongly and hard, is a little bit suspicious that the heart's already being affected and it's not functioning in the way that it should be. But that's a minor factor. Okay, so the question is, what's the treatment? Probably thinking about stuff like, well, got to give it antibiotics. Yep, on antibiotics. Have to give it fluids. Yes, we're on fluids. Have to maybe try to supplement colloidal osmotic pressure with, back then we used synthetic colloids because it wasn't black labeled yet then. So that's one of the things that we thought about doing. But ultimately, we have to go to surgery, right? That if there's an infection going on, if there's sepsis going on, removing the source of that infection is going to be more important. And so we need to treat the underlying cause. We need to go to surgery. So who here is thinking, yeah, let's go to surgery. Let me do anesthesia. No problem. Well, if you are, then you're braver than I am, because I don't know if we would want to take this patient right to surgery in this situation. Yeah, not stable, definitely not. And so, so what more can we do for this patient to get her stable enough so that she could hopefully survive surgery? And that's where vasopressor support may come from. There are different kinds of vasopressors that we can use. Most of them are targeted at these adrenergic receptors, which have the alpha and beta receptors that will create some of the favorable effects that we're looking for: increase in heart rate, contractility, vasoconstriction, all that. And so the drugs that we tend to think about are things like dopamine and probably norepinephrine. Epinephrine is a vasopressor. It's not something that we use on a regular basis. This is more in a CPR situation that we're thinking about using something like epinephrine. But norepinephrine is probably more commonly used today than any other vasopressor in a critical care setting. Dopamine is still something that is used as well. There's also something called vasopressor if you are lucky enough to have it. This is highly expensive in the United States at the moment, that many places have stopped carrying it, but that's another form of vasopressor that can cause vasoconstriction, smooth muscle constriction, that will lead to increase in blood pressure. So we placed the patient on vasopressor, dopamine CRI. At the time, we were still relying on things like central venous pressure. So we placed a central line, monitored fluid balance, and we provided aggressive fluid therapy with both crystalloid and synthetic colloids. And we took the patient to surgery. We repaired the dehiscence that had occurred from the previous surgery, and place an abdominal drain so that we can continue to monitor the drainage that was going on. And we brought her back and had her survive the surgery. And actually, she survived the whole thing. I'll tell you that. But she did spend, her family did spend $12,000 with us. And then, even though we got her over the surgery, she had recovered quite well, and we were almost, thinking that we were going to be able to send her home. But then she kept on developing this pleural effusion that just wouldn't go away. It was cultured. We took a look at what may have been causing it, provided supportive care, and it didn't go away for about a week. And so then she was referred to a small animal internal medicine specialist. And they did more diagnostics and care over there, spent another $15,000, and the owner was able to take care of all those fees, which is great. And she was finally able to go home. That they found out that it was a specific type of bacteria that was sensitive to gentamicin, and so that's all we had to give in order to have her turn around. And why we didn't see that with the first culture, not sure, but eventually that was what seemed to be the cause, and so she did go home. This case really emphasized to me the technician or the nurse's role in all this. Is that we were the ones that detected the decline in the patient, the signs that we needed to look out for. We had knowledge of the interventions, which allowed us to support the veterinary team in the best way possible in order to get her ready to go to surgery. And then all that diligent care, which was both post-op from the first operation and post-op from the second operation, that really led her to her survival. And so the role that we play is hugely important. And so I want everyone to realize that as technicians within the veterinary team, we play a huge role and we influence the patient's outcome quite a bit. And so all this knowledge is very important. So here's one last type of shock that we should talk about. Shell shock? No, just kidding. That's all I have for you guys regarding circulatory shock at the moment. Let me know if you have any questions. Hi everyone, my name is Ken Yagi, and I'm here to talk a little bit about red blood cells and anemia. So when we think about phases of shock, there's many different types of shock that we can think of when we're asked that question. One could be hypovolemic, where there's a lack of intravascular volume that leads to a lack of perfusion and shock. Could be cardiogenic, where there's a poor functioning heart that reduces the forward flow, which reduces perfusion, which leads to shock. There's distributive forms of shock, like septic shock, where blood flow isn't properly performed, that pools in different kinds of areas because of a vasodilation and such that could occur. And there's also obstructive shock, where large vessels are blocked in some kind of way, which prevents good blood flow, which leads to shock. These are all circulatory forms of shock. And people tend to not realize that there's actually other types of shock that has completely nothing to do with circulation, and that even though circulation could be functioning properly, they could still fall into shock. One of them would be hypoxemic shock, where there's respiratory issues, where oxygen is unable to get into the blood, and so then the oxygen isn't delivered to the tissues. And then there's metabolic forms of shock, where there's hypoglycemia, where there's no sugar, mitochondrial dysfunction, and that's all substrate-based shock. And so that's why I tend to say there's two phases of shock that we all need to pay attention to, and they're both bad and ugly. And so we're going to talk a little bit about the blood oxygen content side through oxygen carrying capacity. So before we go further into it, we actually have to think about what shock really is. Shock has to do with ATP, in that the production of ATP, which is a form of energy in our body, requires oxygen in order to produce. So you've probably seen something like this in your biology class, where glucose is broken down through glycolysis to turn into pyruvate. That is shuttled into the mitochondria in each of the cells, goes through the citric acid cycle, electron transport chain, oxidative phosphorylation, all these terms and processes that we probably want to just block out of our minds now. But it's that the processes that happen in the mitochondria that produces an exponential amount of ATP, which allows us to perform all the functions that we need. And it's called aerobic respiration, the production of ATP. The process in which it happens is called aerobic respiration. So without any of these portions functioning and the substrates that are required in order to create these energies being delivered to the tissues, there's an inability to produce enough ATP, which leads to shock. And that's actually the definition of shock. And this ATP is very important in that there's so many different kinds of functions that are listed here that depend on ATP being present in order for it to happen. And so if we think about muscle contractions, the heart needs ATP to continue pumping. And that's one of the most fundamental things that need to happen. ATP is needed for in order for an animal to survive. And so in order for that to happen, we said that the aerobic respiration needs to happen. And so DO2, or oxygen delivery, is something that is critical for survival. And again, that's for the body to perform aerobic respiration. There's two key elements that play a role in proper DO2, or delivery of oxygen. One is proper hemodynamic status, where the cardiovascular system is functioning properly. There's good perfusion because there's circulation to the tissues. And then the other side of that is that the blood that's being circulated to the tissues need to contain oxygen. And so there's two key factors that play into arterial oxygen content, which is oxygen carrying capacity, which is what we're going to talk about today, and oxygenation, which is respiratory function, which is another topic in itself. When we think about DO2, there's actually a formula that goes along with the ability for us to calculate how much delivery of oxygen could be happening. The exact number of this isn't really what's important, but knowing the concept is very valuable. And so if we break down this complex looking formula into what DO2 actually is, we can break it down into simple components, where delivery of oxygen is actually a function of arterial oxygen content, how much oxygen is being carried in the blood, and cardiac output, how quickly and how much of the blood the body is circulating. And we can break down the arterial oxygen content into further components as well, where there's the hemoglobin level, how much hemoglobin is contained in the blood, so the number of red blood cells and the concentration of hemoglobin within the red blood cells, hemoglobin saturation, which is in the middle here, which is how much of that hemoglobin actually can be bound to oxygen to carry it. And then there's some dissolved oxygen in the plasma and in the liquid that just exists in gas form, which all contribute to delivery of oxygen. And it's really on the hemoglobin side and how well that can get saturated with oxygen that the majority, 98% of oxygen delivery happens on. And so that's hemoglobin, and the ability for that hemoglobin to be saturated with oxygen is going to be critical in maintaining good delivery of oxygen. And it's these hemoglobin molecules that we probably remember from biology class, that it's a tetramer. It has 4 oxygen binding sites. It represents the oxygen carrying capacity of our blood. The way that we can take a simplistic look at this is that it's like a truck that can carry 4 molecules of oxygen, travels through the body, through the blood vessels, and we think of that as the roads that get to the tissues, drop off these oxygen molecules, and then come back to the lungs, load more oxygen molecules, goes back to the heart, and then gets pumped out to the rest of the tissues again to drop it off again. And that's kind of the cycle that happens. And so hemoglobin is this almost like a truck that carries these oxygen molecules to the tissues and then back to the lungs, loading more on, and so and then goes to the tissues and offloads it again. And so hemoglobin loads and unloads oxygen molecules depending on where they are. Now, that's how oxygen is delivered, but we also have to think about how oxygen is consumed. And so oxygen consumption is another concept that we should be thinking about, which is called VO2 instead of DO2. And this is just basically the rate at which oxygen is consumed by the body. It really depends on the metabolic rate of the tissues that we're talking about that changes that. And so there's different kinds of things that could increase or decrease metabolic rates. Physical activity, increase in physical activity would increase the oxygen consumption. Shivering is a form of movement that the body has that will consume oxygen as well. Pain and anxiety can increase the amount of movement that the patients are going to have, but also increases the metabolic rate without even physical movement considered. That increases the metabolic activity. Drugs can upregulate or downregulate metabolic rate. Mechanical ventilation I just have on there because if you think about it, mechanical ventilation is used often to reduce the amount of work that the body needs to do in order to breathe, which reduces the amount of oxygen that needs to be consumed or used in order to continue that breathing. And so there's different kinds of things that change metabolic rates for sure. And combining those two concepts of delivery of oxygen and consumption of oxygen, we can actually conceptualize a ratio called oxygen extraction ratio, which is VO2 over DO2. So oxygen consumption over delivered oxygen. So if you think about this in a simplistic manner, as long as we're delivering more oxygen than the body needs to consume, then we should be fine, right? And so if this ratio is less than 1, you're good. And normally, it really is below 1 in that it's anywhere from 30 to 50% that there may be low levels of activity metabolic rate in the body when you're resting versus there might be some increase in activity that increases the amount of oxygen that is being consumed. But within 30 to 50%, you're feeling pretty good. There's nothing wrong and your body is normal. Now, as the level of oxygen consumption goes up or the delivery of oxygen goes down, we're eventually going to hit something called the critical oxygen extraction ratio, where the amount of oxygen that's being delivered to the tissues is going to be less than what the tissue needs. You'd think that should actually be 100%, but depending on the body and the tissue that you're talking about, some of those tissues require more oxygen than the others. And so when you take a look at the body as a whole, it's actually not when it gets to 100% oxygen extraction ratio, it's 70% because some tissues require more oxygen than the other. And then from there, the level of oxygen delivered versus the level of oxygen consumed becomes a more one-to-one in ratio nature, where there's this very significant slope here where the oxygen extraction ratio is 100% and the body can only consume the amount of oxygen that's actually being delivered. Maybe the other way to put it is that it's using every molecule of oxygen that it's having delivered to the body because it's needing to use as much as they can get. It's sort of the concept of you can't spend any more money than you actually have in your hand, and so the cells can't utilize more oxygen than they are having delivered, and so they're basically using all the molecules that are being delivered which makes the DO2 and VO2 be at a 1-to-1 ratio, which is the oxygen extraction ratio of 100%. And when you're in that situation, the body is in huge trouble. And that's where we tend to see signs, clinical signs. And if it's related to anemia, which is a reduction in oxygen carrying capacity, that's when we call it clinical anemia. That means that there's not enough oxygen to meet the demands. There's clinical signs that show up because of it. These are things like the animal is weak. You start to see compensatory signs where there's an increase in the heart rate. The body's trying to circulate as much oxygen as fast as possible, increasing the cardiac output. Because there's not enough oxygen in the body, there's an increase in respiratory rate and respiratory effort in order to try to get more oxygen into the blood. And then because it's not sufficient, the delivery of oxygen level is not sufficient, you start to see impaired mentation in these animals as well. That's when metabolic acidosis starts to happen, lactate production increases, and so a hyperlactatemia leads to lactic acidosis. And it's when an animal reaches this state because there's a reduction in the oxygen carrying capacity, the number of red blood cells, the concentration of the red blood cell, or the function of the red blood cells, is when we have an animal that's clinical because of an anemia. That's why we call it clinical anemia. So let's take a look at a patient here. You have an anemic patient. It's a 12-year-old male neutered domestic medium hair that comes in. Upon arrival, it's a referral, and you know that the PCV at the referring veterinarian was 6%, pretty darn low. Total protein was 11.6, kind of high. The mentation was obtunded or depressed or dull, however you'd like to put that, but it's not normal. The mucous membrane color is pale pink. The capillary refill time is less than 2 seconds, which is pretty normal. Blood pressure is normal, 120/89, with a mean of 99. What's the cause here? What kind of guesses do you have? Now, when we think about the reasons why this animal could be anemic, because it's clear that the patient is anemic and it's in trouble, there's many different things that we need to consider. The first of which is red blood cell loss. This means that the animal is hemorrhaging, it's losing red blood cells because it's leaking out of the vessels. It could be internal or external bleeding that's going on. It could be acute, which is a quick onset that not anemia, but blood loss that has happened, or a gradual one, or chronic red blood cell loss that's been going on. Could be related to something like trauma, where there's a gross destruction of tissues and blood vessels that makes the animal bleed. Could be surgical accidents where vessels are cut and there's more bleeding going on. Could be things like neoplasm, which has acute bleeding that's going on because maybe it's something like this, a splenic mass that's ruptured and the animal's bleeding very quickly. Or it could be neoplasms that lead to slower oozing of blood and loss over a course of time. One major type of red blood cell loss can be categorized as coagulopathy. This is where animals show signs like these, that we have bruising going on because there's lack of coagulation, petechiation in gums that you can see because the animal isn't clotting very well. Place a catheter. This happens to be a central line that has been placed, and the insertion site of the catheter just doesn't stop bleeding. Or it could be much more overt signs of bleeding, like this animal who continues to bleed from the nose and it won't stop. There's different forms of coagulopathies for sure. Now, when we think about hemostasis and the ability for the body to clot, and we know that it's always trying to make a decision of whether they should clot or not clot this form of bleeding that's going on. And that's all based off of balance of these 4 forces that's within your screen right now. There's antithrombosis, which is, actually, let me start with thrombosis on the bottom left here. There's thrombosis, which is the ability for the body to clot to begin with, so that we can stop the bleeding when bleeding happens. But we don't want clots to be forming everywhere, and so there's normally an antithrombotic effect that goes through proteins. These are all coagulation proteins that we're talking about, that balances that to make sure that clotting only happens when it's supposed to. And then there's fibrinolysis, which breaks down the clots that had formed after the repair has been completed. And then because we don't want clots to be broken down before the repair has been made, there's an anti-fibrinolysis effect on the fibrinolysis to prevent breakdown of clots wherever they to prevent breakdown of clots when it's not ready to be broken down. And so then each of these forces work against each other or with each other in order to provide good hemostasis. So keeping that in mind, let's think about another patient. Patient presents. This is Dama that came in. She had difficulty breathing. She's coughing up blood. She walks into the emergency room and she has blood all over herself because she's coughing up blood. Because she's having difficulty breathing, we're hearing crackles. We take her to radiology and take an x-ray. Well, that stressed her out. She arrested in radiology. We quickly intubated her and started breathing for her heart. Her heart never really stopped, but the breathing stopped. And we had to put her on a mechanical ventilator for the short term eventually, but we had an emergency procedure here. The x-ray that was taken, it was kind of costly to take that x-ray, but we got it, showed pulmonary infiltrate. Thinking that this was a coagulopathy, we took a PT-PDT and saw that they were both prolonged. And in these situations, we often think about rat bait, for example. And so we asked the owner if they know of any rat bait that was in the area. Could she have gotten into any? The owner said, no, like we haven't put any out, but let me ask the neighbors. And so they went back home and asked around and came back and said, sure enough, that one of the neighbors had put out rat bait in their yard a week or two ago. And so that may be what she got into. And so this is an example of pulmonary hemorrhaging occurring because of anticoagulant ingestion. It's a toxicity that occurred. Now, this is a situation where normally vitamin K is a substance that's circulating within the body in order to create normal active coagulation factors, which allows the animal to have enough coagulation factors, clotting factors, to clot as they need. And this is how it normally works, that vitamin K hydroquinone, which is the active form of vitamin K, is used as a cofactor to turn inactive coagulation factors into active coagulation factors, but in that process becomes vitamin K epoxide, which is an inactive form of vitamin K. The vitamin K epoxide, the inactive form, is actually turned back into the active form towards the left over here through the activity of an enzyme called vitamin K epoxide reductase. And so that's what normally happens, is that vitamin K is recirculating from the active form on the left side to the inactive form on the right side, but being converted back to the active form on the left side as more and more coagulation factors are activated. What rat bait does is that it comes and blocks this enzyme from functioning properly. And what tends to happen is that because the body still needs to create active coagulation factors, more and more of the active form is used in order to create the active form of coagulation factors, which then is converted to the inactive vitamin K. As time goes on, there is going to be a depleted amount of active vitamin K in the circulation, which then prevents reduces and actually eliminates the ability for the body to create active coagulation factors. Okay, well, there's remaining active coagulation factors that gets used as there's normal wear and tear. There's coagulation factors that get used up, it gets depleted, and then the animal starts to bleed because there's no more active coagulation factors. So this is called vitamin K antagonism. It's a coagulation factor activation defect, meaning that as time goes on, this is an acquired form of a bleeding disorder because of this blocking of the enzyme that occurs. So it's not really antagonizing vitamin K themselves, but antagonizing the ability for vitamin K to be recycled into the active form. So when we think about this situation and go back to this chart, what happens is that there's a coagulation factor deficit that occurs because of the blocking of the enzyme, which means that there's a reduction in fibrin activation, which leads to thrombosis or clot formation. And so this force gets diminished. And so the animal doesn't clot. So what's the treatment for this? What do we normally give these patients? If you said plasma, you're right in that we tend to give something like fresh frozen plasma in this situation so that we can provide that active form of coagulation factors. This is an animal that's already bleeding into the lungs so much that a little bit of stress puts them over the edge to arrest. We need to really replace that active coagulation factor right away, so we do a plasma transfusion. But the real treatment is vitamin K, in that we replace this active form of vitamin K by injecting it first of all, and then maybe following with orals, which then re-establishes this pathway in which the inactive coagulation factor can become active coagulation factors, and then providing that vitamin K until the body has the ability to excrete and eliminate the toxin that it just ingested, the rat bait that we're talking about, so that this enzyme is back to normal function, allowing the patient to continue creating active coagulation factors. And that takes several weeks for it to happen. So there's two forms of treatment here. One, immediately replacing the active coagulation factor through a plasma transfusion, and then two, replenishing the vitamin K so that the animal can have normal production of active coagulation factors themselves. So that's just one form of coagulopathy, though. Went over that a little bit in detail because it's interesting how it works. There's something called synthetic failure, where the liver isn't working very well. Maybe it's toxins that's damaged the liver. Maybe there's an infection going on with the liver. Hepatic lipidosis is a form of an issue that could occur with the liver where there will be a good amount of inflammation that occurs. But whatever the reason is, the effect of liver damage is going to be that there's the loss of protein production, synthesis, and both procoagulant and anticoagulant proteins will be diminished. So if we think about it from this chart again, all of these forces start to be diminished because there's a lack of procoagulant and anticoagulant protein production. So then you think, do they balance themselves out? No, actually, because if there's no clotting to begin with, then there's just no clotting. It doesn't matter that there's a reduced amount of antithrombosis or fibrinolysis. There's no thrombosis to begin with. So then they start to bleed. Yep, and there's different kinds of synthetic defects in addition to that could occur as well. Other coagulopathies, if we think about it, there could be a overdose of coagulation inhibitors. It could be related to drug ingestion or increased amount or too high an amount of anticoagulant being administered, like heparin. That's something that we need to be worried about when we're giving heparin. There is something called acquired hemophilia, where when an animal is exposed to coagulation factors, say through a plasma transfusion, that they build an immunity to it. It's relatively speaking rare, but that's one way where coagulation factors can be diminished and that the immune system removes it. There's something called hyperfibrinolysis that could occur, where the animal has overactive clot dissolving activity because of different diseases as well. We also can't forget platelet disorders. That's a whole lecture by itself, but platelet dysfunction or platelet reduction is going to lead to a coagulopathy that we're not able to clot. And then in addition to that, there's all sorts of inherited coagulopathies that is in the chart over there. I think hemophilia A and B, which is a factor 8 and 9 deficiency, is something that we hear about more commonly than any other hereditary coagulation factor deficits, but any of these factors could be diminished because of a hereditary issue. So this question of clot or not to clot, the decision not to clot is a huge issue, especially if you're this dog pretty soon when the cat explodes. Yeah. Okay. Well, there's other sorts of red blood cell loss that could occur as well. And so this is a photo of an example of an animal that was just given a bath. And because of all the flea dirt that was on this cat, the blood or the fluid, the bath that was clear in terms of the water is turning blood red. So ectoparasites is another way that animals could lose blood, fleas, ticks, and lice infestations. It affects younger animals more so than larger animals, but large animals are also not an exception. That this is a goat that came in anemic because of a lice infestation and also was pregnant at the same time, so was losing iron to the fetus, and so then became very anemic. Endoparasites are also forms of blood loss, that there could be intestinal worms and such that cause internal hemorrhaging. Gastroenteritis is another way that they definitely lose hydration and intravascular fluid volume because of the water loss, but if there is enough of a mucosal breakdown, there's going to be bleeding as well, which leads to an anemia. And so GI ulceration is another form of loss of blood through the GI tract. All right, whatever the reason is, these were all different kinds of reasons why the animal could be anemic, but whatever the reason is, the signs of red blood cell loss is going to be that there's some regenerative changes that we could see on the CBC, meaning that there's different kinds of changes related to hyperproduction of red blood cells, different size red blood cells, different concentration of hemoglobin within the red blood cell, because they're trying to push out, relatively speaking, incomplete red blood cells into circulation. If it's an acute bleeding that's going on, then you see signs of hypovolemia, loss of intravascular volume. It could be that there's hypoproteinemia as well, because proteins are being lost faster than it can be replaced. Signs of bleeding, if it's external, probably would see it. If it's internal, might be a little bit harder to visibly see it, but there may be fluid accumulation in different kinds of cavities. So this patient that we were talking about, the total protein is 11.6, so we're not hypoproteinemic, so it's probably not acute bleeding or anything like that that's going on. Mucous membrane color is pale, consistent with anemia, and CRT is normal. Blood pressure is normal as well, so we're not seeing signs of hypovolemia. And with the photo, you can see that there's no external signs of bleeding going on. And I'll tell you that there was no internal signs of bleeding either. So was it red blood cell loss? Probably not. So then the second category of red blood cell or causes of anemia would be red blood cell destruction. And this is where there's two different forms of ways in which red blood cells could be destroyed. First would be intravascular hemolysis, meaning that the red blood cells are bursted, broken, whatever you want to see. Like there's hemolysis that occurs that leads to hemoglobin release, and so then the hemoglobin circulates within the blood. It goes to the kidneys. It gets filtered out by the kidneys, and so then you see something like hemoglobinemia, which is hemoglobin within the bloodstream, hemoglobinuria, hemoglobin being excreted out with the urine. There's also something called extravascular hemolysis, where the immune system breaks down the red blood cells and breaks it all down, and so there's bilirubin release from hemoglobin being broken down, and that's where we see things like hyperbilirubinemia, where there's an increase in the orangeness of the serum because there's bilirubin in it, and also bilirubinuria that gets filtered out by the kidneys and out into the urine. Now, in terms of different kinds of reasons why extravascular or intravascular hemolysis could occur, one of them is called type 2 hypersensitivity. Cytotoxic reaction may be a term that you've heard of before. It's a immune-mediated hemolysis that occurs because of IgM and IgG molecules that circulate within the body. It just happens to be that if there are red blood cells that are circulating and there are immunoglobulins that think that they are foreign, they will latch on based on their binding sites that they have. A couple of things will happen. One is complement proteins will bind onto it and activate the complement system, which can lead to intravascular hemolysis. And so this is direct hemolysis that occurs because of the complement system being activated. If you think about the complement molecules binding onto this and sort of pushing the IgG molecules apart, that almost like thinking about a bag of potato chips being opened up, like pulled on, and then eventually it bursts open. That's what direct hemolysis looks like. And so then hemoglobin goes all over the place. There's also extravascular hemolysis occurs, that the binding of these IgG molecules onto the surface of the red blood cell opsonizes it, meaning that it marks it as foreign, and the immune system knows that it needs to destroy it, and so it's marked for destruction. So then the mononuclear phagocytic system, which includes the white blood cells, things like that, monocytes, come in and break down the red blood cells. So then it leads to bilirubin release. So in addition to the opsonization and the complement related destruction that happens, there's also agglutination that could occur. And agglutination occurs when there's red blood cells floating around in the bloodstream. There's IgM molecules, often IgM molecules. It could happen with IgG molecules too, but IgM molecules come by and say that this red blood cell has binding sites that I like, and so it latches onto it. Well, there's probably more red blood cells that have the same binding sites, and IgM molecules that bind onto these surface proteins and such that serve as binding sites. And before you know it, it turns into this huge clump. And that's why you start to see big enough clumps that you can macroscopically see the clumping of the blood. Now, these are all forms of signs that you can see that will lead you to think that it's immune-mediated hemolysis. The agglutination that occurs, the jaundice that happens because of the hyperbilirubinemia, these are all signs of immune-mediated issues. And there's different kinds of immune-mediated hemolysis that could occur. One is considered secondary IMHA, where there's external factors that contribute to immune-mediated hemolytic reaction. Could be related to cancer. Could be that drugs are administered, they adhere to the surface of the red blood cells, and immunoglobulins think that's foreign. Could be related to infection, where there's infections of the red blood cells that affect the red blood cells, and then the immune system breaks down the red blood cells along with the infection. It could be acquired immune-mediated hemolytic anemia, where there's transfusions that are given, and it sensitizes the patient to destroy those red blood cells, which leads to anemia, or a hyperactive immune system that leads to anemia. There's something called neonatal isoerythrolysis that could also occur in infants, that neonates, when they take in colostrum of their mother, it contains immunoglobulins against their own red blood cells that gets absorbed passively into the bloodstream, and then so they attack their own red blood cells through those immunoglobulins. Now, when there's no secondary reasons or external reasons for the immune-mediated hemolysis to occur, and it's truly their own immune system attacking their red blood cells, that's when it's called primary immune-mediated hemolytic anemia, or autoimmune hemolytic anemia. So I just wanted to let you know that IMHA and AIHA are not synonymous. AIHA is a type of IMHA. Let's take a look at Burton over here. Burton, who is a 4-year-old male-neutered dog, came in lethargic. He's vomiting, looks jaundiced, has a low PCV, and there's a sign of hemoglobinemia, although he's yellow looking at the same time as well. And that's how he presented. What's going on here? Because he was vomiting, there was a radiograph that was taken, and happened to find something that looks like this. What is this? If you thought it was a coin, then you're right. If you take a look at this, and we flip it around, does that look familiar? It's actually a penny. And so, this is called Heinz body anemia, where there's different kinds of chemicals, whether it's from onions, garlics. You probably know that animals aren't supposed to eat those. It could be coin related, in that there's different kinds of chemicals that animals can be exposed to, which leads to Heinz body formation. And these Heinz bodies are denaturing of the hemoglobin as a protein because of the chemical exposure, which then leads to different kinds of things, that the hemoglobin is not functioning very well. They can lead to these inclusion bodies. That's what those arrows are pointing to, is that the red blood cells get deformed because of an accumulation of the denatured hemoglobin, which leads to extravascular hemolysis because it looks foreign and the immune system takes care of it, or intravascular hemolysis when there's enough of an accumulation of these denatured hemoglobin that the red blood cells burst. What's interesting about this one is that cats tend to tolerate the deformity of the red blood cells a little bit better, and that the immune system doesn't remove it right away. In that when you see a slide like this, it's usually in a cat, not so much in a dog. Now, can one penny kill is a good question to ask, and the answer might be pretty surprising. If you think about the LD50 of zinc, what it is at the dosage at which 50% of the population would die and 50% of the population would live being exposed to it. For zinc, that's 100 milligrams per kilogram. A penny weighs 2.5 grams in weight. It's actually 97.5% zinc, and that copper color on the outside is just the coating that it has. So it's mainly made out of zinc. So that's 2,400 milligrams of zinc in a penny. What that works out to is that 1 penny will kill 50% of 52.8 pounds or 24 kilogram dogs. And that's a pretty big size. So a 50-pound dog could eat a penny and then have a half and half chance of surviving or dying. It's pretty bad. And oftentimes many animals could eat more than one coin, or they could be a pretty small dog at the same time. So 1 penny can definitely kill. Other causes of hemolysis, these are relatively speaking minor factors, but there's mechanical damage that can happen to red blood cells if there's cardiac disease and there's weird flow of blood. The blood cells are running into each other, running into unusual blood flow, and so it gets mechanically damaged. Hemangiosarcoma changes vasculature often, and so they're squeezing through smaller blood streams and sustaining damage. Patent ductus arteriosus is a process example of a way in which red blood cells could flow back and forth between vessels that don't naturally flow in that direction, and so then they're sustaining more mechanical damage. Heartworm disease is another one where if the heart looks something like this, then the patient's probably already dead. But when you have think about several worms being in place, narrowing blood flow or bloodstream or areas in which red blood cells could flow through, and it's sort of being pushed through meshes of worms, you could probably see that it also sustains mechanical damage. Electrolyte abnormalities like hypophosphatemia, that could happen with patients like that have diabetes mellitus, refeeding syndrome. There's not enough phosphate to create the ATPs, and so the ATP is lacking, which means that the red blood cell wall isn't able to be maintained as well, which leads to reduced integrity, so the red blood cells can more easily burst. So all of these lead to intravascular hemolysis. Well, signs of red blood cell destruction would be that it's still regenerative because the body has the ability to regenerate red blood cells. It just is losing it faster than it can replace it. There may be signs of agglutination. If it's immune mediated, then you might see that. Mostly you'll see signs of byproducts of red blood cell destruction. If it's intravascular hemolysis, that's hemoglobinemia, hemoglobinuria. If it's extravascular hemolysis, that's being jaundiced or being icteric, hyperbilirubinemia, or hyperbilirubinuria. Now, for this particular patient that we were looking at, this is what the PCV tube looked like. So it doesn't look very yellow, it doesn't look very red. Mucous membrane color is pale, so it's not yellow or anything like that. And so it probably wasn't red blood cell destruction that was going on. So then the third form of anemia and the reasons that could happen is through abnormalities in red blood cell destruction. And so this is where normally when you think about how red blood cell is produced, the kidneys produce something called erythropoietin, which is a hormone which stimulates the bone marrow to start producing red blood cells, which then turns into final product in about 4 days or so. And the erythropoietin level is determined by the oxygen level within the blood. So if there's low oxygen level, then it responds to that to try to increase the amount of red blood cells that's out there. If there's a higher amount of oxygen level, then it kind of cuts back on that so that the red blood cells don't need to make as much red blood cells. And that's how it normally happens. Now, there are different ways in which erythropoietin issues could arise as well, and this is a diagram of the receptor working and how that works downstream. The details aren't what's really important, but we do need to know that the erythropoietins are contained in the kidney. So if there's kidney disease and there's damage to the kidneys, there's a reduction of these receptors for EPO. There also could be a blunted response to the hormones because of inflammatory disease that occurs, or there's a reduction of EPO receptors because of the inflammatory mediators that are in circulation. And so even though the kidneys are producing the right amount of erythropoietin to try to drive red blood cell production, the body has a lack of ability to respond to it. It could be the bone marrows that have issues, because the bone marrows are what produce the red blood cells, that even if the signals are fine, the ability to produce might be affected. This could be viral or bacterial infections, toxicities, irradiation. Sometimes we irradiate the marrow on purpose to reduce the activity. It could be neoplasia that's taking over the bone marrows, or it could be immune-mediated destruction. So there's different kinds of reasons that could happen. Now, there could be nutrient deficiency as well. This dog definitely doesn't have any nutrition deficiencies, but when we think about nutrient deficiencies that lead to anemia, folic acid, vitamin B12, cobalt deficiencies will lead to defective red blood cells, which get destroyed. A lack of iron would mean that there's not enough hemoglobin that's going to be contained in the red blood cells, or production of red blood cells could be delayed. And each of these deficiencies can have different kinds of causes. It could be that they're just lacking the intake of it, so it's they're eating a nutrient deficient diet, which could lead to it. Folate antagonism could occur within the body. It could be a genetic reason that certain functions of the cell isn't working appropriately, or it also could be related to inflammation, where if there's enough inflammation going on, the liver releases something called hepcidin, which leads to a loss of iron store release, is what happens. And so here's an example of a cat. You probably have seen patients that look like this, where it's being affected by different forms of red blood cell issues that lead to anemia. So this is a patient with chronic kidney disease, in case that didn't strike as one. But when you give phosphate binders, which are white liquid typically, and they start trying to spit that out, and the foamy liquid that comes out is blood tinged like this, it's because of the oral and GI ulceration that's occurring. So this is a situation where chronic kidney disease, you have uremic toxins that cause platelet dysfunction, which leads to the inability to maintain the surface of the oral mucosa. And in these situations, we definitely want to provide the patient gastroprotectants, analgesic agents, but it does serve as a source of blood loss. So chronic kidney disease, there's a reduction of nutrient intake, and so we're losing out on nutrients that lead to better red blood cell production. There's a reduction of erythropoietin production because the kidneys aren't functioning properly. Uremic toxins lead to more loss of red blood cells, as well as lack of platelet function. And it also decreases the half-life of the red blood cells themselves, so the red blood cells don't survive in the body as long. It also reduces iron store release. And so if you think about all the reasons that stack up against chronic kidney disease patients in terms of the level of red blood cells that's circulating within the body, you can see how they become so anemic. So back to that anemic patient, the 12-year-old that we talked about, that came in with a PCV of 6%, total protein of 11.6. Was it hemorrhaging? No, it didn't look like it. Was it hemolysis? Nope, no signs of that either. So is it a production issue? And just by thinking about that, yeah, it could be a production issue. And some of the information that I didn't give you right up front is that with the CBC, we saw that the white blood cell count was pretty darn high, unusual. This isn't like, the usual, because of an infection, there's an increase in white blood cell. This is astronomically high. And so when one type of cell, the level of one type of cell is hugely increased, you start to think about things like cancer. And so there was a liver aspirate performed, and it allowed us to confirm that this was actually something called plasma cell myeloma. There was B cells that were increased in the amount, and the reason for this patient's anemia then likely became something called myeloptosis. And what that is that there's the white blood cell lineage within the bone marrow that is growing in a cancerous manner, which pushes out all the other types of cell lines within the bone marrow, and it was overwhelming the space, and the red blood cells weren't able to be produced, which leads to the PCV being at 6%. And you could also make sense of the total protein of 11.6 being very high, in that the beta cells produce antibodies, and so there was a huge amount of proteins circulating. And so we were able to confirm that by protein electrophoresis, seeing that the total protein of 11.6, those proteins were gamma immunoglobulins. So those were all reasons why red blood cell count could go down. And so the last question that we have to ask ourselves, and we'll cover, is can patients have inadequate oxygen carrying capacity even though their levels are normal? And the answer to that is yes. And here's an example of a patient that came in with something that falls into this category. So if you take a look at this patient's cage card, this is what it would say. The differential diagnosis, you can see that it says cytokine toxicity or methemoglobinemia. And this is a situation where it's fairly prominent in that the color of the blood changes to this dark red color because of an accumulation of a certain kind of dysfunctional hemoglobin. Normal hemoglobin has ferrous iron, which has a red color, and it binds oxygen just fine. But when it goes through oxidative damage, it turns into this ferric hemoglobin, or methemoglobin, which has ferric iron. It has a brown color, and it's unable to bind oxygen as well. It causes left shift in oxygen hemoglobin dissociation curve as well. Now, fortunately, normally, even though oxidative damage is something that happens on a regular basis, there's a hormone that converts the methemoglobin back into normal hemoglobin, such that the amount of methemoglobin that's circulating in the body is at any point in time of only about 2%. And so it's not a huge issue normally, but if there are chemicals that the hemoglobin gets exposed to that creates this oxidative damage at a higher rate, that's when animals start to get into trouble. And so methemoglobin can be formed by different kinds of chemical exposure again. And so here's an example of a patient who has a brown mucous membrane color because of methemoglobinemia. Now, the treatment to methemoglobinemia is that we need to provide diuresis, in that we get these chemicals to be excreted out of the body. And so speeding that process up through diuresis is one of the ways to do it. And then there's also N-acetylcysteine, which we can provide the patient. It's a form of drug that will help them supplement the amount of these enzymes that convert it back into normal hemoglobin. So it increases the rate at which the hemoglobin is turned back to normal. Now, there are some forms of inherited CB5R, which is the enzyme that we're talking about, deficiencies that could occur. And so if you've seen this gentleman's information circulating within the internet, he is from a family of people who have this inherited genetic CB5R deficiency. And in people, apparently, it turns the skin blue. And so I've read that somewhat recently, within years, this gentleman had also passed away, and so he was the last of the line of his family. But it does explain other kinds of blue people that may be around, and maybe they have methemoglobinemia. The form of treatment that we provide for methemoglobinemia is acetylcysteine. And so this is a pretty common treatment protocol that you see for this, is that we would normally provide 140 milligram per kilogram initial dose, and after that we would provide a 70 milligram per kilogram dose, say QID, for example, diluted, so that it's 5% instead of 20% that it comes in, and giving it over 20 minutes slowly through a syringe pump with a filter. Another form of dysfunctional hemoglobin is carboxyhemoglobin, and this is when they're exposed to carbon monoxide. So smoke inhalation, gas furnaces, things like that. Carbon monoxide has a much higher affinity for hemoglobin than oxygen does, or I should say hemoglobin has a much higher affinity for carbon monoxide than oxygen. So it can outcompete oxygen in binding onto the hemoglobin, and it reduces the oxygen carrying capacity by 50% because it binds on, if you think about the tetramer, the two opposing ends binding up two of the binding sites, 2 of the 4 binding sites. And it turns the hemoglobin into a cherry red color. So causes are things like smoke inhalation, being exposed to car exhaust, heating systems, gas generators, things like that. The treatment of it, the only real treatment for it is competitive oxygen therapy, that if you provide a higher amount of oxygen, even though the affinity for carbon monoxide is higher than oxygen, you can outcompete just by sheer number of oxygen molecules that are circulating. So by providing oxygen supplementation, you allow the animal to exhale more of these carbon monoxide molecules, which allows them to get rid of it from their body. Now, there's also an interesting form of hemoglobin called sulfhemoglobin. It's pretty rare. We don't see it in clinical practice very much because it doesn't happen very often, but it's when hemoglobin forms a bond with sulfide compounds. And so these are usually toxic ingestions of antimicrobials that have sulfides in them. The only treatment that we have for this is also supportive in that we try to provide diuresis and things like that. What's interesting about it is that it turns the blood green. And so this is a photo of a laboratory-made sulfhemoglobin. Now you can see it's clearly green. And so if you see a person walking around in San Francisco that looks like this, maybe they have sulfhemoglobin. Actually, one of my colleagues actually has seen a sulfhemoglobinemia case, and I asked about what the mucous membrane color looked like. She said that it looked actually kind of brownish, but when you push down on it to check the CRT, as the color is trying to come back, the tissue underneath is green tinged. So definitely an interesting presentation. Now, how do we tell what kind of hemoglobin is within the bloodstream? That's where we have to rely on something called co-oximetry. Instead of pulse oximetry, it's co-oximetry. And co-oximeters have the ability to distinguish the different kinds of hemoglobin that absorb different kinds of spectrum of light, which allows us to tell what kind of dysfunctional hemoglobin is present. And so that information allows us to think about the concept between functional versus fractional saturation of oxygen. When we think about pulse oximeters, what it's actually measuring is functional hemoglobin, meaning that it's taking a look at the proportion of oxyhemoglobin versus the total hemoglobin, whether it's oxyhemoglobin or deoxyhemoglobin total. So 98% means that 98% is oxyhemoglobin versus the 100% that's present that it's able to determine. So it's a measure of oxygenation and pulmonary function. Now, when we have dysfunctional hemoglobin in the mix, pulse oximeters don't work anymore because it could say 100%, and it could be that 80% of function. It could be that the 100% of what's functional is what's saturated. Now, let me try to explain that a little bit better. if we think about an animal that has methemoglobinemia, let's just say that 20% of the hemoglobin is oxidated and it's methemoglobin. That means that there's 80% of normal hemoglobin level that is available to be oxygenated. And so if 98% of the 80% gets oxygenated, the pulse oximeter will still say 100% or 98%. But it's in truth only about 80%, which is way less than what we need in terms of survival. And so we need to think about dysfunctional hemoglobin, and the fractional SO2 turns into a formula that looks something like this. What is the proportion of oxyhemoglobin compared to the total hemoglobin, both oxygenated, deoxygenated, methemoglobin, carboxyhemoglobin, sulfhemoglobin, whatever it is, and then figuring that out. And so it incorporates all hemoglobin species present, which becomes important when we know that animals, a certain patient has exposure to factors that could cause dysfunctional hemoglobins. So whatever all that reason is, whether it's anemia, whether it's dysfunctional hemoglobin, how do we treat oxygen carrying capacity issues? Well, we have to treat the underlying cause. If it's bleeding, surgical interventions. If it's toxins, antidotes, and diuresis is what we need. If it's hemoglobin destruction or red blood cell destruction, immunosuppression might be needed. Ectoendoparasite issues that lead to bleeding, we need to treat that. If it's organ issues that's causing the loss of red blood cells, then we'll need to try to treat that. Maybe there's nutrient supplementation that's needed. While these treatments take effect, it's not going to immediately reverse the oxygen carrying capacity issue, and so oxygen carrying capacity needs to be supplemented during that time. The first option to supplementing oxygen carrying capacity is red blood cells, transfusions. Whether it's packed red blood cell or whole blood, it increases circulating red blood cell mass. There is the downside of it causing immunologic or non-immunologic complications, so we need to make sure that we assess the risk of the patient very closely, do proper compatibility testing, monitor the patient closely while transfusions are going, and we'll make it as safe as possible. We do know that red blood cells are limited in supply, that we can't get it very easily sometimes, that it's on order but back ordered. We have a finite amount that we keep in our blood bank, and so you may not have an infinite amount of it. And so then the question turns to, are there other options out there? And there are other options out there, although it's very hard to have on hand these days, that the hemoglobin-based oxygen carry solutions, which are solutions that carry hemoglobin molecules. Oxyglobin was one that we used to have in the United States. We now don't. It's a bovine origin, polymerized hemoglobin. It has a specific half-life. There's all this great stuff about it that actually makes it a better oxygen carrier than natural hemoglobin for some of these species. But with that said, it's no longer FDA approved, it's no longer on the market, and so we don't have this available anymore. Now, here's a photo from some of my colleagues, and this was provided by a dear friend, Louise, that just shows us that oxyglobin is available or was available in the European countries, and when they had it, they liked it. It seemed like it was very useful and effective, but at the same time, there's some complications that you need to be worried about related to increased oncotic pressure as well as potential kidney issues that could arise. But with all that said, the hemoglobin-based oxygen carrying solutions are very difficult to find out on the market these days, and so we may not have that very readily available at all. Hopefully it comes back. Other oxygen carrying options are things that have been looked into are things like perfluorocarbon molecules that can bind oxygen, nanotech synthetic red blood cells that are able to also carry oxygen and are small as red blood cells, or stem cell derived red blood cells, which are stem cell grown red blood cells that are red blood cells themselves. And so those are options that are currently being looked into. And so there's different kinds of articles that we tend to see. This is a relatively old one several years ago. And here's a relatively new one just 1 year ago, where there's still progress being made in order for us to be able to supplement oxygen carrying capacity in the safest way possible and not having to depend on blood banks and donations, which is often limited. So hopefully science continues to make progress on this end and it becomes more and more available, but there's not a simple solution just yet. So hopefully I was able to give you a good overview of oxygen carrying capacity, anemia, as well as some of the issues surrounding it. Please let me know if you have any questions, and thank you very much for listening. Imagine yourself as a dog trainer who is having a session out in the field with a bunch of your clients, and one of them all of a sudden says, "Oh my God, my dog just fell over. I don't think he's breathing." Would you know how to do? And this is actually something that happened, and there was headlines all over the news saying, "Heroic dog obedience trainer performs CPR on animal and saves lives." This is the obedience trainer performing CPR, doing some chest compressions. And I'd like you to think about whether this is the way that you would perform CPR, or if there are other things that you would be doing, or things you would be doing differently. Here he is checking the airway, purple tongue, giving a breath, and then going back to compressions. Any comments that you have about how he might be performing compressions, performing CPR in general? After a little while of this going on, surprisingly, this animal actually comes back. So this is our dog here, disoriented for sure, but looking pink, looking around, having awareness. And this dog came back. Being offered a bowl of water. He says, "No, thank you. I almost died. Let's go to the hospital." But this was certainly something that swept the news. And this was before things were so easy to go viral and such, but it still went around. It makes us think, how should people be performing CPR on dogs out there? And even though you probably, as we were watching the obedience trainer perform CPR, thought that that's not the way to perform CPR, he certainly is a hero in that he stepped in, he did what he could with the knowledge that he had, and maybe this wasn't a complete cardiopulmonary arrest situation where maybe this animal was actually fainted, that there was a syncopal episode. I'm not sure, but he did step in, and he is a hero, and we want to make sure that we recognize that. But it makes us think about, how should we be performing CPR out there when something like this happens? Now, does CPR look more like this at your practice? And I hope the answer is yes, that you have somebody performing compressions on a regular basis at a certain rate that we talk about. There's a bunch of people who are working on placing a catheter, getting the patient intubated. And the most common comment that we get about this video is that we don't have that many people, which could be true depending on the size of your practice and the time of the day and the shift that you're on, things like that. This is a pretty large hospital during the daytime, and so we have a good number of people coming around. But that probably looks a little bit more like how you perform CPR. Or does it look like this? And hopefully not, but the doctor yelling, "Get the epi, hook up the ECG, get a tube in, do we have an IV yet?" And "Do it all now," as his spit flies all over the place. Hopefully that's not how it looks, but maybe it does. And so then through all this, there may be some questions that come to mind. How much epinephrine? What does the ECG show us, and why do we need it? What should we do first when there's all these competing interests and orders are flying around? And that's where the Recover Initiative, which is also called, which stands for Reassessment Campaign on Veterinary Resuscitation, published a guideline in 2012 that took a look at all the evidence out there that they could find regarding key questions surrounding CPR and put it together as a set of guidelines to help us perform CPR based on evidence. And that guideline can be boiled down to this one algorithm when it comes to performing CPR. It starts at the very top over here with an ABC assessment of an unresponsive patient. We check for A, the airway, to see if it's patent or occluded. If it's occluded, then we need to remove whatever the occlusion is. B, for breathing, is the patient breathing? And C, for circulation, is the heart beating? Can we feel pulses? And out of these, the C is in quotes because we now recommend that we don't spend a whole lot of time really being sure if the patient's heart has stopped or not. This is because we know by evidence that even highly trained medical professionals can mistakenly feel for a pulse when there isn't one present, and vice versa at about 40% chance. And so by the time that the patient isn't breathing, we know that the patient's going to have the heart's going to stop in the near future, and so we go ahead and start CPR. So then we initiate CPR. The core of CPR is in basic life support. We provide compressions and ventilations. Compressions for circulations, ventilations for the oxygenation. And if we are in an in-hospital setting, then we initiate monitoring. We'll talk about which monitors, obtain vascular access, and administer reversals. And then we go into the general flow of CPR. So if you take this blue box at the top where it says initiate CPR immediately and put it down here, in the bottom of this flow, that's the basic life support part. We're providing compressions, performing that for 2 minutes long. Once 2 minutes is over, we evaluate the patient. We evaluate the patient by checking the ECG. If it's in hospital, we would listen to the heart, palpate for the pulses, things like that. And if the answer to that evaluation is, oh, the patient's back, we've achieved return of spontaneous circulation, great. Then we take care of the patient and go on to the post-CPA algorithm, which is another set of algorithm that's available through this guideline. But many of the times, the answer will be, no, we haven't gotten the patient back. And so then, depending on what kind of ECG rhythm that we see, we'll do several different things, and we'll talk about what those are, and then go back to compressions and basic life support, 2 minutes of doing that. And so it's 2 minutes of compressions, ventilation, monitoring the patient and the quality of the compressions, and then going back to number 2, evaluate the patient to see if the patient's back. And then depending on what ECG we see, there's different ALS interventions we would perform, and then we go back to compression. So it fits into this 2 minutes of compressions and ventilations, performing CPR, evaluating the patient, and depending on what you see in the ECG, doing different things, and then going back to 2 minutes of compressions. 2 minutes of compressions, evaluate the patient, do what you need to do. 2 minutes of compressions, evaluate the patient, do what you need to do. 2 minutes of compressions, evaluate the patient, and then do what you need to do. And that's the flow of CPR until you achieve return of spontaneous circulation where you get the patient back, or you call the patient dead. And that's how CPR works now. So let's talk first about compressions, which is the number one most important thing about CPR, creating circulations. In terms of compression techniques, there's several things that we could say about this. Number one, we have to start immediately, that once the patient has fallen into cardiopulmonary arrest, the longer you leave the patient without any kind of blood flow, which is what compressions create, the lower the chance of survival for the patient is. And so we want to start as soon as possible. The rate should be 100 to 120 compressions per minute. The depth should be, the depth of compression should be, if this is the full width that we're talking about, 1/3 to 1/2 of the chest width. And so we need to push pretty hard in order to achieve that for a larger animal. For a smaller patient, you may need to moderate your force in order to not overcompress and then damage the internal organs. In between each of those compressions, we allow for full recoil so that there's the biggest difference between the positive intrathoracic pressure that you're creating by pushing down and then negative intrathoracic pressure that you're creating by allowing the chest to bounce back. And we perform that for 2 minutes uninterrupted, and we'll talk about the reasons on that, but it's to create the maximum amount of blood flow that you can with your chest compressions and sustain that for a short duration. And then there's a certain compression point that we focus on. And so that compression point depends on the conformation of the patient. This is a patient who is just as wide as they are deep, and so they're considered round-chested. In these animals, we try to push down on the highest point of the chest, the widest point of the chest. So if this is the contour of the neck, and then the chest gets wider and then narrows down, it's the widest point both this way, sideways, and this way. And that's where you put the heel of your palm so that you create a chest compression point. And this is a method in which we utilize something called the thoracic pump theory, in which that when you push down on the chest cavity, the rib cage itself, it creates a positive intrathoracic pressure where the positive pressure squishes down on the blood vessels, and then the veins are the ones that are flaccid enough that they will collapse. And the blood, as it collapses, blood flow is directed both forward and backwards, but there's valves in place that prevent it from going fully backwards, and so most of it goes forward and it goes into the arterial system that doesn't collapse. When you allow for the recoil and allow the chest to re-expand, it creates negative pressure which pulls the blood from the abdomen into the chest, which then you push down on again in order to create that forward flow, and you do that over and over, so you're using the chest cavity as a pump. What about these animals? These animals are keel-chested animals who are much, much narrower than they are deep. So you could probably see that they have a very deep chest with a narrow width to it. And so for these animals, the end of the chest comes down into a triangle where the heart sits, and so you could conceivably think about pushing down on the chest, over the heart, to pump the heart itself and use that as a conduit for, not just a conduit for blood, but an actual pump for the blood itself. And so we utilize something called the cardiac pump theory to use the heart as a pump in order to drive the blood flow. All right, what about these alien-looking creatures, the weird ones that are flat-chested? They are much, much wider than they are deep, which is kind of like us, right? People are flat-chested in that we are much, much wider than we are deep. And for people, we push on the sternum. And so for these animals who are flat-chested, we would utilize the cardiac pump theory by pushing over the sternum. And I just want to remind everyone, though, that this is a pretty rare situation in that there are not too many, relatively speaking, truly flat-chested animals. And so if you have an animal that you put on their back and they stay on their back, great, they're probably flat-chested. If you put them on their back and they start to roll over, then they're probably more round-chested. And so you got to take a look at that animal per animal. So this is an example of a round-chested animal. Just about as wide as they are deep. And so the red dot shows the widest portion of the chest and where we would push. This is a narrow-chested dog that even though this is a pretty darn big dog, we would push over the heart because we can think about pushing down on the heart to use it as a pump itself. Now, what about this one? This is a truly flat-chested animal where you can see that the dog is much, much wider than he is deep, where he's alive and he's trying to get up and he can't even get up. And so this is truly a flat-chested animal, just like a turtle, and we would be pushing on the sternum for these guys. So close. All right, yeah, so I've heard that this dog is still there, and mom in the back doesn't care. She's been through that, been there, done that, got to let the son figure that out. So that would be a truly flat-chested animal. All right, going back to chest compressions, in terms of recumbency, a lot of people ask, should they be on the right side down, left side down? Yeah, I mean, we can theorize about that, but there's no evidence regarding which is superior over the other, so there's no significant difference in terms of lateral recumbency chest compressions that we're performing for particular dogs. If we were thinking about doing open chest cardiac massage, then the approach from the left side is anatomically easier to perform. And so being right side down just as a habit, if you're not delaying CPR being started, might be the way to go, but that's about the only considerations to make. The physical tips of how you perform CPR is to make sure that you have your hand over hand, shoulder over your hands, and locking your elbows as you are pushing down. And when we say hand over hand, we really mean your hand over hand. You can interlace your fingers and then push this way, interlock your fingers, push this way. It doesn't really matter as long as the heel of your palm, this area, is overlapping with each other so that you're creating a compression point instead of like this where you would create a compression area. And so like this, not like this. And so here's an example of a front view and a side view of proper compressions. Hand over hand, elbows locked, shoulder over the heel of your palm. And you can see that there's a good perpendicular angle here going into the patient, into the table, so that none of the force is going towards sliding the patient around. It's going directly into the patient. What about small animals? Well, small animals may look something like this, cats and small dogs, where you can perform what's considered the circumferential one-handed technique right over the heart and compressing the heart. And so this cat obviously has no recoil. It's a stuffed animal, and so we can't show that very well, but we certainly would want to see the recoil happening even in these small animals. The key point when we're performing compressions for these guys, one-handed circumferential, is to make sure that you're using V-shaped compression of your fingers where you're pushing your thumb up against the rest of the fingers versus a C-shaped compression technique. And the reason why is that because if you think about the heart sitting in the neck of the V there, if you use a V-shaped compression, you can see that you're pushing the ventricles of the heart from the bottom up and really ejecting the blood out of the heart. Whereas if you're performing a C-shaped compressions and pushing at the top, you're just squishing the blood around in the atrium and maybe into the ventricles, but you're not really effectively pushing the blood out as though you're doing a V-shaped compression. So V-shaped instead of C-shaped. All right, the question was going to be, what song do you sing in your head as you're performing CPR and compressions? And staying alive is one of the common ones that people think about because it's just about 100. It's 104 beats per minute. And so if you go along with the beat of this sound or this song, then you're probably performing compressions at the right speed. And obviously people like the optimistic message as compared to another one, Bites the Dust, which is also around the same beat, but much more pessimistic in terms of the title. But with that said, there's so many other songs that you can use out there. You don't have to go along with those two classic ones that we tend to think about when we think about this. Paradise City may not be the best song to sing in your head. Suddenly I See might be a good thing. But that's just the first page. Here's the second page, and there's a lot of songs that you could think about. Common one that people tend to sing in their heads these days is Baby Shark. I'm not going to play that to be nice, but that's another one that people think about these days. So pick your song, make sure that you can sing it properly while you're performing CPR, because you could definitely sing it too fast or too slow, depending on how your mind is. And so getting it into your physical muscle memory is probably going to be important. This is a picture of Dr. Fletcher and I, along with Dr. Ueda and Dr. Hune, who are both involved in the Recover Initiative quite a bit. We went to Japan to train our first group of Recover CPR instructors so that we can spread this internationally. And so this is a photo from there. And during the training session in Japan, I remember Dr. Fletcher coming to me and saying like, oh my God, I don't know, Ken, like, I don't know about this, because he's noticing that people are just not getting the rhythm really well in terms of compressions. And so we're telling them, just like Staying Alive, you know, the Bee Gees, Staying Alive. And they're like, staying what? Like, we don't know that song. But we eventually found a song that did work for them, which was the Beatles. He's one of the emergency doctors in Japan who is very, very active, and he's a clown, obviously. But after we found a song that actually was familiar to them, their rhythm became much, much better. And so then we felt better about the training that was going on. The main point is that depending on the country that you're in, depending on the region that you're in, there may be different kinds of songs that work better for them. And then after we were there for a few days, we realized that there's actually a cartoon character, which is the stuffed animal here, called Doraemon, who pretty much every Japanese person knows as they grow up during their childhood, and the theme song is just about the right rate. And so when we started playing that, then things were much more better in sync. All right, but it is an international effort. All right, so what do you think about this compression by this person? It's important for us to be able to assess people's compression quality just by looking at them from the external and giving them feedback. So elbows are locked, pretty forceful, Shoulders probably over the patient, full recoil, which is good. The only thing that I would say about this compression is maybe where the compression point is and how the hands are overlapping. A little bit of this is maybe not as good as having the heels of your palm overlapped with each other, and so that's what I would recommend. But otherwise, it looked pretty darn good. And we also mentioned that we perform CPR with 2-minute compression cycles without interruption. And there's a reason for that. And this is from the online course as well, but it actually takes quite a bit of time. It's about 60 seconds before we can actually build up blood flow by performing consistent compressions. And so interruptions are really bad. If we interrupt compressions, that blood flow that we built up very significantly drops down. And so we have very little, we have a huge reduction of perfusion during these pauses that happen. And it takes time to build that back up. And so in order for the patients to get as much blood flow as possible through compressions, which really is only about 30% of what a spontaneously beating heart can create, we need to perform uninterrupted compressions. So here's a graph that shows as the compressions are being performed, it takes time, 60 seconds, to build up to the maximum blood flow that we can create with compressions, and we want to sustain that by performing compressions. Every time it's interrupted, it goes down. So keep the compressions going. If we say, have to listen to the heart, get out of the way, I got to do compressions. All right, let me intubate, whatever it is, whatever the reason is that makes us stop compressions in that 2-minute cycle, you can see that the difference is pretty darn big in that here's the maximum flow that we could have created at the dotted line compared to the actual flow that we created by interrupting much more frequently, which is along the gray graph. So don't interrupt those compressions. What used to happen was that we would be performing CPR, the doctor would come in and say, okay, hold on, let me listen to the heart. So then you stop compressions. That's pretty normal, but these days we don't do that. We say, we're mid-cycle, let's finish this out, and then assess the patient. And so recommendations, limit your rhythm checks to every 2 minutes, less than 10 seconds in between compressions to make that assessment, and switch the compressor every 2 minutes so that the person doesn't get too tired doing the second 2-minute cycle. And if you have performed CPR and if you have performed compressions and follow the recovery guideline to perform that 2 minutes in a row, you know that 2 minutes of compression is actually pretty darn strenuous. All right, so that was all compressions, and now we're going to think about ventilation. We spent a lot of time talking about chest compressions, and it's largely because there's a reason why chest compression is #1 on this algorithm. It's the most important part about CPR, meaning that it creates blood flow. Because we're going to talk about ventilation, which is a way to get oxygen into the bloodstream and CO2 out, but if there's no blood flow, it doesn't matter how many times or how well we breathe for the patient. We talk about administering reversals and other drugs during CPR. It doesn't matter if we get those drugs in if there's no circulation. So chest compressions and doing that well is the #1 most important thing about CPR. All right, now we're going to move into ventilation. Ventilation. We used to, when we have an animal that crashed, we are starting to perform CPR on, we may have tried to intubate first, and then once we got the patient intubated, started compressions. And so we used to say something like the ABCs of CPR, airway, breathing, circulation, which sort of made its sense, and it went along really well. But when you go to like an airport, or if you've seen these machines laying around in some of the public areas, it's called CPR on the go. But what I want you to pay attention to is that this is a machine that has this creepy chest model in there in the middle of the airport. Nobody's using it. But what I want you to pay attention to over here is hands-only CPR on the go and what that says. This is a machine that helps people train on something called hands-only CPR. In the human medicine side, for lay people, they've started to teach hands-only CPR because out of everything that this person could be doing to try to help a person that has had a sudden cardiac arrest is to just go ahead and perform CPR, or compressions. And so without even worrying about the breathing, just getting chest compressions, we know, is going to help the patient possibly recover. And so the ABC of CPR has actually changed to CAB of CPR. We start the chest compressions, get circulation going right away, and then we think about delivering breaths. And what that translates into on the veterinary medicine side is that we prioritize compressions. We don't stop compressions to intubate. Lateral recumbency intubation is commonly performed, and so we should definitely practice that if there's opportunity to do so with routine procedures that you may have, so that you're ready to do so when a patient arrests. All right, that ventilation, what does that look like? Well, it depends on the situation. If you're in a single rescuer situation, or you're in a setting that you don't have endotracheal tube available, then we have to perform something called mouth to snout ventilation. And that's what the trainer was sort of trying to perform on that video that we were taking a look at, where we close the mouth completely, seal the mouth, put your mouth over the nose so you have a full seal, and then you blow in briskly. And then we want to see if there's chest excursion that occurs. And the two key points that are really important in this process is to keep the neck straight so that the airway isn't bent in any kind of way, that you're not allowing the neck to flex or bend sideways, which bends the airway, increasing the airway resistance that makes the air go into the GI tract instead of the airway should you try to deliver the breath. 1 second inspiratory time is still what we think about. We perform this 30-to-2 ratio in terms of compressions to ventilation ratio. So 30 compressions and then 2 breaths. Now, we won't focus on that too much because in veterinary practices, oftentimes we have the ability to intubate, and hopefully that's the case for you in your practice, that we use an ambibag or a machine after we intubate to perform that. And so this is an example of an anesthetic machine being used to deliver the breath. The breaths are delivered 10 breaths per minute at a rate of 10 breaths per minute, or every 6 seconds. 1 second inspiratory time. Hopefully you have a spring pop-off valve that looks like this, where you can not, you don't have to worry about leaving it accidentally closed. But you can see that we're delivering a breath. 1 second, squeeze, and then just let go. Squeeze, and then let go. You do that every 6 seconds. The manometer, it's hard to see on this video, but we push to about 20 to 40 centimeters of water, in that there's some pressure that we're pushing up against with the compression that we do need to get a good amount of pressure going in order to deliver the air into the lungs itself. And up to about 40 centimeters of water, at least short term, doesn't cause a whole lot of damage to the lungs. Okay, so more often though, that ambibag may be a little bit safer to perform ventilation through, because it tends to have a pop-off, automatic pop-off that will go off when there's 40 centimeters of water pressure that's been built up. And so this is what that looks like. That compressions are going, and the breaths are being given once every 6 seconds. Nice brisk breath, not squeezing the bag too long, and delivering that breath. All right, and so that was ventilation. And so that's all still basic life support. Starting compressions, getting circulation going, starting ventilation so that we can get oxygenation started as well. And then within that first cycle of compressions, we would initiate monitoring, which is number 3. And so I have a question for you here. Which of the following is the best measure for effective perfusion in CPR? How do we judge circulation that we're creating through our compressions during CPR? And so there's a bunch of options here for you: palpable pulses, end tidal CO2, Doppler, ECG, or lactate. And hopefully what you said was end tidal CO2 for that particular question. And we'll talk about why that is, but also thought that ECG is useful during CPR as well. And so these are the two big monitors during CPR that's going to be useful. When we think about capnography, here's a simple diagram of alveoli that has air moving in and out, blood coming in deoxygenated from the rest of the body, carbon dioxide rich, and CO2 comes out into the alveoli. Air moves in and out of the alveoli, removing the CO2, bringing oxygen in. Oxygen goes into the bloodstream, and then it gets carried out to the rest of the body. And so proper gas exchange requires good perfusion, blood flow in this bloodstream, and ventilation, movement of air in and out of this alveoli. And so ventilation and perfusion leads to end-tidal CO2, which is being measured at the outside of the mouth and the airway as it comes out of the lungs. We talked about ventilation always being 1 breath per 6 seconds, 1 second inspiratory time, and performing that on a consistent basis, which means that the ventilation isn't going to change too much during CPR. What can change, though, is perfusion, in that if you're performing great compressions and you're creating good perfusion, then the amount of end-tidal CO2 is going to be larger. So the more perfusion you can create, the more end-tidal CO2 you will get, because the oxygen is being delivered to the tissues, there's CO2 being produced by the cells, and then the CO2 is being brought back to the lungs to be measured by the end-tidal CO2 outside of the body. But the opposite is true too, that if you're doing poor compressions and the perfusion is lower, then the amount of end-tidal CO2 that you're going to be getting is lower as well. And so this capnography, it's useful for being able to assess the quality of compressions of the blood flow that you're creating. It's also good for confirming intubation. If you are intubating the trachea and you're in the airway, if you're creating some kind of circulation, you're going to be able to register CO2 coming out. If you are in the esophagus and the GI tract, there's likely going to be very little CO2 that will register. It's also considered a predictor of return of spontaneous circulation, meaning that if you're performing great compressions, you're getting an end-tidal CO2 value of greater than 15 millimeters of mercury. Just taking a look at the evidence in the literature out there, the comparison between groups that were able to achieve higher than 15 millimeters of mercury versus lower than 15 millimeters of mercury, we know that the group with higher than 15 millimeters of mercury is associated with a higher rate of return of spontaneous circulation. So we want to put them in that group. And what does that mean? That means that if the end-tidal CO2 is put on, the end-tidal CO2 value is less than 15 millimeters of mercury, then we need to do everything that we can, checking how basic life support is being performed. Are we performing compressions in the way that we should be technique-wise, the rate, the posture, the elbows being locked, are we allowing for full recoil, are we pushing on the right compression point? All of that stuff needs to be troubleshot so that we can bring the end-tidal CO2 up higher than 15 millimeters of mercury. It's also an indicator of return of spontaneous circulation, meaning that we said that with the manual chest compressions that we're performing, we can create about 30% of what a spontaneously beating heart can actually perform or create. So then if the heart starts to beat on its own and all of a sudden takes over, it's going to go from 30% to 100%, hopefully, of what the circulation the animal can actually create. And so then there's a whole lot of CO2 that comes back to the lungs and out to be monitored by or measured by the end-tidal CO2 probe, which serves as an indicator for return of spontaneous circulation. So it's useful for many different kinds of things. Now, this is what the monitor could look like during CPR. You can see that the chest compressions and the breath that was given created this plateau on the end-tidal CO2. The value is not that great because it's 6. We want that to be higher than 15. And then the ECG is just showing artifacts of the compressions here. But you can see that there's compression-induced ventilation that's happening, which is air moving in and out because of the compressions. Another breath was given. There's another plateau. The number is 10, which is still not that great. But the end-tidal CO2 is something that we closely pay attention to try to change how we're performing compressions in order to create better blood flow. All right, so the key pieces that we're looking at during CPR is end tidal CO2 during compressions to see how well we are performing compressions to create blood flow. The value that we're looking for is greater than 15, 6 isn't that great. And then the ECG, we'll be taking a look at in between compression cycles, because you can see that during the compression cycle, you really can't tell what's going on. These are just mechanical activity that is being registered. Some of the other monitors that people may want to use during CPR might be Doppler or oscillometric blood pressure machines. There's not a consistent pulse being generated during CPR that's going to be measurable, that the blood pressure isn't going to be useful. Some people say putting the Doppler on the eye will help you listen to the blood flow getting to the head, but there's a lot of tissue movement, there's a lot of body movement that can translate into those sounds, and so we don't think that's useful anymore. Pulse palpation is something that we can definitely have if you have the extra people to keep a hand on the pulse or keep a finger on the pulse to see if there is pulses being generated by the patient's spontaneously beating heart. That would be great. The thing to watch out for there is that really good compressions could create venous pulsations because it sort of tenses up the venous system, and so that's something that you could be feeling as you're palpating for pulse when compressions are going. Those would likely go along with the compressions themselves instead of it being asynchronous from the compressions. So that's something to keep in mind. Pulse oximetry, we joke around and say that pulse oxes don't work when the patient's alive, and so why would it work when they're dead? No, that's just a joke. But it's true in that during CPR, we're utilizing drugs often that causes vasoconstriction. There's probably vasoconstriction going on that's pretty significant from the body itself. And there's a lot of motion, and so pulse oximetry that depends on consistent pulses being detected isn't useful during CPR. All right, so that's monitors, and we'll talk about ECG a little bit later too, but I want to just slip in vascular access here, that during CPR we're going to need vascular access so that we can administer things like reversals. And so that's where drugs and venous access comes into play. You probably have a crash cart that looks something like this, where you have the emergency drugs laid out nicely in one of the drawers. A key tool that we tend to use during CPR is something like this. Easy IO is what this device is called, but it's a intraosseous drill that allows us to place an IO catheter very quickly. This is a drill that's sitting in the emergency area, just in the cabinet. All you have to do is take it out, put the needle on, and then push it up against the bone surface that you want to place the IO in, and then drill it in place.
Angled more caudally than
video?
cranially. And I push it through the skin until we hit the bone, and then go more or less perpendicular to slightly caudally. Okay.
And so you can see that Dr. Ellis there was just giving instructions on how to do this, and that only took about 30 seconds to do. In an emergency situation, all you have to do is clip off a little bit of the the hair in the area or not, and then push the needle up against the bone, pull the trigger, drill it in, and then that top part you can screw off, and it turns into an IV port that you can stick an IV line onto and start infusing fluids or giving drugs or whatever you need to do. And so some animals may be very difficult to place an IV catheter while there's no absolute blood pressure and there's no pooling of blood that you can create by holding off a vein, things like that. That allows us to facilitate the ability to gain venous access. Now, once we have venous access, here are the emergency drugs that we tend to use during CPR. The arrest drugs at the top, we'll talk about these as well, antiarrhythmics, reversals, and this chart also has defibrillation dosages too. And so having something like this available in an emergency CPR area is going to allow you to take a look at and look up the amount that you need to give very quickly. Okay, so let's talk about reversals. The main reversals that are used during CPR is naloxone, flumazenil, and anapamazole. Naloxone is to reverse opioids, flumazenil is to reverse benzodiazepines, and anapamazole is to reverse alpha-2 agonists, so things like dexmedetomidine. And the guidelines, the recovery guidelines, definitely recommend reversing whatever drugs may be on board that could cause any kind of issues in terms of cardiovascular suppressant effect and respiratory depressant effects. Okay, so going further into the advanced life support, we have defibrillation and antiarrhythmics, as well as epinephrine or atropine and vasopressin dosing. And so we'll talk about that next. And this is all dependent on what the ECG of the patient looks like when you're in between those 2-minute compression cycles and taking a look at the patient. The ECG rhythms can be split up into 2 big categories. Are they a shockable rhythm on the left side, ventricular fibrillation, pulseless ventricular tachycardia? Or are they a non-shockable rhythm on the right side, asystole or PEA? And so the way to determine whether they are shockable or non-shockable rhythms, I'm borrowing Recover's simple ECG algorithm that Dr. Fletcher has put together for us. The first question that you ask yourself when you take a look at the rhythm is, are there consistent repeating complexes? And if the answer is yes, then you ask, are there pulses associated with these complexes? If the answer is yes, then great, you have return of spontaneous circulation. There's a rhythm, ECG rhythm, there are pulses, the heart must be beating. So that's what you want to aim for. But if the answer is no, there's another question that you ask, is the rate greater than 200 or less than 200? If the answer is yes, it's greater than 200, then we know that we should classify it as pulseless ventricular tachycardia. It's a shockable rhythm, so we should shock. If the answer is no, we consider it pulseless electrical activity, so we don't shock it. It's a non-shockable rhythm. Now, if the answer to the first question was no, then the next question that we ask is the ECG a flat line? If the answer is yes, it's asystole, it's a non-shockable rhythm. If the answer is no, it's not a flat line, it's going up and down, it's random, then it's ventricular fibrillation. It's a shockable rhythm. And so that's how the ECG algorithm works. So if we were to quickly use that on something like this, the ECG tracing looking like this, are there consistent repeating complexes? The answer is no. Is the ECG a flat line? The answer is yes. This is considered asystole, so we don't shock. It's a non-shockable rhythm. If the ECG looks something like this, complexes, are there pulses associated with it? I'll tell you, no, there wasn't. This patient still seems to be not in ROSC. What does the rate look like? And you could probably tell that it's a little bit of slow rate. And so this is PEA, pulseless electrical activity. If it looks like this, are there consistent repeating complexes? No. It's random looking. Is the ECG a flat line? The answer is no. And so it's ventricular fibrillation. It's a shockable rhythm. What if it looks like this? Are there consistent repeating complexes? The answer is yes. Are there pulses associated with it? I will tell you no. And so we move down this way. Is the rate greater than 200 or less than 200? And let's just say it's greater than 200. It's pulseless ventricular tachycardia, so we should shock. It's a shockable rhythm. And this is just to show how that ECG rhythm diagnosis works. And it's these 4 main rhythms that you'll see during CPR that you need to respond to. And so we talked about shockable versus non-shockable. The non-shockable rhythm, the most common rhythm that you'll see is asystole. And so if there's no electrical activity, there's no mechanical activity, just make sure that the ECG leads haven't fallen off or anything like that. But if that's if the ECG leads are still on and that's what you're seeing, then there's no perfusion. You have to resume compressions in order to create that perfusion. If it's pulseless electrical activity, this is when you have repeating complexes, the patient is pulseless and the rate is less than 200, then you still don't have good perfusion going on. It's a non-shockable rhythm, so you go ahead and resume compressions. And then we think about providing drugs like epinephrine. And these CPR drugs, there's many of them out there that we tend to use. We can break it down into vasopressors and vagolytics. And so epinephrine is a vasopressor that we would be using during CPR. It creates peripheral vasoconstriction. And it's important because by causing peripheral vasoconstriction, we're pushing the blood to the core of the body, which is where it needs to be during CPR, in that we want to provide the most blood flow to the heart, the lungs, and the brain to try to sustain basic life. And so we try to create the most perfusion going to those organs to allow the patient to start beating their heart more, back to being spontaneously beating their heart. There's low dose and high dose epinephrine. If you take a look at the drug chart, that there's two different dosages that are noted there. Low dose epinephrine is what we tend to use until there's prolonged CPR and we think that we just need to give something more. And the difference between the two is that low dose epinephrine has a lower chance of return of spontaneous circulation, but a higher chance of survival to discharge. The high dose causes so much vasoconstriction that we may be causing more damage to the vital organs around the heart and the lungs and the brain that leads to poor survival. So high dose, even though is associated with higher chance of return of spontaneous circulation, we leave it till we have no other choice. Vasopressin is similar to epinephrine. There's some theoretical benefit to it that in severe acidemia, it may be able to, the receptors still may be more functional than the receptors for epinephrine, but it's a theoretical benefit. There's no evidence to show one is superior over the other, but it can be used as a vasopressor. Atropine has no evidence to show benefit or harm during CPR, and so we kind of say if people want to give it, they can. Many people tend to use it when they're patient is suspected to have arrested due to some kind of vagal tone being present. So an animal that had a coughing fit and collapsed, that was vomiting and collapsed, things like that. All right, the epinephrine is what I want to focus on, epinephrine or vasopressin. The vasopressors are what's given when non-shockable rhythms are determined, and then it's given every other cycle because epinephrine has a short half-life and it's about 3 to 5 minutes, and so giving it every 4 minutes, which is every other cycle, seems to be pretty good. All right, if you have a shockable rhythm, then these are things like ventricular fibrillation. There could be coarse ventricular fibrillation where there's a lot more electrical activity versus fine ventricular fibrillation, or pulseless ventricular tachycardia, repeatable rhythms. The patient is pulseless, greater than 200 compression or the beats per minute is what we're seeing. These are considered shockable rhythms, and so we have to use a defibrillator. And this is what defibrillation could look like. This is going to be internal, but here's ventricular fibrillation that you're seeing on the video. The heart's just jiggling because all the myofibers are firing randomly on their own accord. And so then we deliver an electrical jolt through defibrillation, and it stops the heart temporarily, allowing the sinoatrial node to take back over and start beating the heart more in unison if it works well. That was internal defibrillation that you saw, but many times we would have external defibrillation that we would be using, and these are hand paddles. When you have hand paddles like this, you would need to have the team put them in dorsal recumbency, put the paddles on both sides of the heart, squeeze really hard, hold on patient, call for clear, get everyone out of the way, including yourself, not touching the patient or the table or anything like that, and then delivering the shock and then going right back to compressions. What if you don't have a defibrillator? Then the only thing you can do is mechanical defibrillation. And this is the process in which you see in the movies, somebody gets pulled out of the river and then they say, "You're not going to die on me today," and then boom, like hits the chest, and then the patient starts, or the person starts coughing up, water, seaweed, fish, whatever they have swallowed, and they come back to life. It doesn't work very well, that well in real life, in that there's no evidence to show that this is very effective. But at the same time, if you don't have electrical defibrillators, that's the only real option that you have. So all this information should be available in your emergency area where you're performing surgery. Anesthetic arrests are something that could happen. So wherever CPR would be performed, you should have nice, easily visible cognitive aids like these that allow you to perform CPR along with the algorithm and determine the dosage very quickly. And so this is in the surgery room for the hospital. All right, the other part that we could talk about more in detail, but I'll just quickly go over, is that the recovery guidelines also recommend communication styles or communication methods during CPR, having clear, direct communication saying, "Ken, can you go get the epinephrine, low dose?" And then closed loop communication. When that's given, I would say, yes, getting low dose epinephrine and pulling up 0.25 cc's for this patient, 25 kilograms, giving the epinephrine, and then the leader saying, great, thank you very much, epinephrine's been given, and then so then we record it. So having that closed loop communication is going to make sure that people are on the same page, and there are less likely for mistakes to be made. If I had said, okay, getting atropine, then they would be able to say, no, I said epinephrine, and redirect me. And then for everyone to be situationally aware, keeping in mind what's going on, engaged in the entire CPR process, not just what they are doing, and cross-monitoring each other so that we can notice when there are errors that are about to be made. And then afterwards, making sure that we debrief and talk about what happened, what went well, what could have gone better, how are we going to prepare for the next one. And also some of these the CPR attempts could be very emotional, and so then we should be talking about the emotional side of this too, to allow for people to express their thoughts and feelings. And so, all right, so let's just say you get that patient back. We achieved return of spontaneous circulation. Then we have this post-cardiac arrest care algorithm that's also available through the guideline, and there's a lot of different things that we would monitor, but if I was to summarize it in just very quick terms, then we know that we're going to be taking care of and monitoring the respiratory system, optimizing that through oxygenation, ventilation support. We would provide hemodynamic support through vasopressors, different kinds of means, fluid therapy, and we would also be performing neuroprotective therapy. And there's a lot of different knowledge in the human medicine side regarding active cooling and reducing the metabolic rate, things like that. But on the animal side, it's mainly about giving mannitol and things like that to reduce the cerebral edema. But that's the three key parts about post-cardiac arrest care. And there's, again, a whole section of the manuscript on the guidelines related to it. All right, so that's the RECOVER guidelines, reassessment campaign on veterinary resuscitation. And so the question that I wanted to ask you about this is, has your practice implemented the RECOVER guideline? And this is one hospital that I used to work at. I was there for the first 17 years of my career. This is the place that I grew up. It's a 24/7 general/emergency practice. It's a pretty big hospital that has 27 veterinarians, probably over 30 at this point in time. But anyways, large hospital that was 24/7 general/emergency. And this is where we implemented the RECOVER guideline. And that's where I ran into the RECOVER guideline first. And the reason why we wanted to implement CPR training was because we wanted to standardize how CPR was being performed. At that point in time, many years ago, there was no official protocol for CPR, and so depending on the doctor that was working on shift, the technicians that were on shift, the team that was on, whether it's nighttime or daytime, do we know each other really well or not? Sometimes CPR would go really well, and we get the patient back, and we feel great about that situation. But then some other times, it would be pretty chaotic. Things just don't click. Orders are being barked out, one direction. Two people would jump at it sometimes, or maybe one person, nobody would jump at it and take care of it. And so then and on top of that, we lose the patient. That was hugely demoralizing. And so there was a lot of instances where we felt helpless and frustrated. Did we do the best for the patient? And so we really needed to fix that. And so by employing the evidence-based guideline, we thought that we would be able to bring in the best current practices. We can make the CPR smooth and standardized and hopefully improve the patient outcome and send the patient home, because that's what we really want in the end, right? That we want to be able to send these patients home. And so there were many challenges to implementing CPR because it's a large-scale training. We needed to adapt the guideline into actual protocol, because it's not like you can just take the guideline manuscript and say, hey, here's the protocol for CPR. You have to adapt it to your own practice setting. And so we created training resources. So we had to do that work first. And then we had to figure out, how are we going to train all these people in a 24/7 hospital that never closes? And there's 4 different departments. There's a bunch of people that we want to train. We ran into some pushback from the very beginning. Is it even worth it? Success rate's pretty low anyways for CPR, so aren't there better places to spend these resources? Will the training actually make a difference? Is it going to change anything? And some people felt like, we already do CPR just fine. Do we really need this? And the last one is, some people said patients die for a reason. Like, why do we want to try to bring these patients back? And obviously, we really hit that hard to say that, some patients, maybe it's at the end of their lifespan. But other patients, like animals that come in for an orthopedic procedure and they rest under anesthesia and they're healthy otherwise, don't we need to know how to perform CPR? And so that's how we pushed back on that pushback. Eventually, we decided that training was going to be worth it. And here's an example of a daytime training session with a bunch of people. Here's another photo from that training session. And then here's a nighttime training session that was done with a smaller number of people. And then we got hungry, so we had sushi dinner. That was really good. And we did the training in a very organized fashion in that we first of all trained the CPR leaders with one session. 11 people were trained to be designated to be CPR leaders. And then we trained, put the CPR leaders with other technicians and assistants to create CPR teams that were trained. And then we put them together with veterinarians and did 5 different sessions, trained 20 of the veterinarians through scenario-based training. And this is all before certification was available. And we repeated that for the second year so that we could train more people. And so the results of that, was it worth it? We had tracked the data on how CPR and their success rate looked. And so I can quickly let you know that the first year after training, this is what it looked like. That 24.1% ROSC, 3.7% was discharged to go home. And then the next year, the number of CPR that we performed, probably because of case selection, went down a little bit, but the ROSC rate was 42.9% and survival to discharge was 7.1. And then the third year, it went up even higher. That the ROSC rate went down a little bit. I don't know why that is, but the survival to discharge was 14.3%. But overall, still a pretty low survival to discharge rate that we talk about. But with that said, I'm hoping that there's a trend upward towards us being able to select the right cases and sending patients home. And so was it worth it? Yeah, the survival to discharge rate was still low. The ROSC rate is a little bit higher, but most importantly, we gained perspective on our performance. And prior to this, we didn't even know how well we were doing it. Another big gain was that we had a huge improvement in teamwork, that the veterinarians were able to focus on the diagnosis for the patient and the treatments that the patient may have needed, as opposed to having to organize CPR and tend to the patient themselves, that the CPR team functioned on its own, that the doctor could focus on the client and the patient. The communication with the client was something that the veterinarian could focus on as well. There was less delay in the CPR interventions that needed to happen. And the technician team was hugely empowered that they were able to run CPR on their own along with the veterinarian, and the communication just kept on improving. Some other intangible gains, we were able to start to have honest, open conversations about CPR with the clients, set realistic expectations. We, in effect, established this code versus no code designation that we could have a conversation with the clients about, which allowed us to perform less CPR based on the current situation for the patient and the in a realistic manner. And we think that's what led to the high return of spontaneous circulation rate. Some other intangible gains, and this is what I was really hoping that would happen, is that we could definitely bring order to the chaos that CPR is, but also lead to less frustrations, have a sense of control in the situation for our team, and so that we don't have that emotional turmoil after a CPR going wrong. And so we surveyed our team members, and comments like these came back, and there's a lot to go over, but I'll just summarize it with the last one, that one of the staff members said, with the new protocol, we're able to do the best job possible. Our patients get the best chance. And so if you could confidently say that our patients always get the best chance, isn't that worth it? And so if the hospital could talk with better efficiency, communication, teamwork, higher morale, hopefully better outcomes as well, hopefully the hospital would say it was totally worth it. So when we think about future directions for evidence-based CPR in veterinary medicine, there's already online CPR course that you can take for basic and advanced life support that's available through the Recover initiative. And so that'll give you the didactic knowledge, and it's for veterinarians and veterinary team members. And there's American College of Veterinary Emergency Critical Care approved certification process where you can be certified in basic and advanced life support. It starts with taking that online course and then getting certification training. This is in person, and there's some telesimulation plans in place right now for the pandemic. And you can become certified as a rescuer. So now you're certified to perform CPR. Then you can take it one more step and become a certified instructor, which allows you to teach people and certify other people in becoming rescuers so that you can teach them how to perform CPR. There's a collaborative data collection database that is globally set up so that there's a registry that's run by Dr. Manuel Boller, and there is a 2021 guideline process in play right now that the guidelines will be updated this year, which is going to be good. And there's also going to be layman training that when we think back on the initial story that we started with, it's about an obedience trainer that needed to perform CPR. And so these people need to learn how to perform CPR on animals as well. So this pet rescuer CPR certification process is what's being developed as well. That allows people to become certified pet rescuers through Recover, and so look out for that as well and becoming instructors. So we'll probably never get to the point that we teach animals how to perform CPR, but that's apparently a thing. Yes, horrible technique. Needs to be trained. But I'll leave you with this story that I've gone a little long already, is that there was a pool cleaner who came to their client's home and saw that this ground squirrel was drowning, and he pulled him out and performed CPR. It's a video of that. And so we'll probably never get to the point where we say there's the ground squirrel CPR guideline, evidence-based guideline, Recover created. Obviously, the heart in a ground squirrel is located in the abdomen because this animal comes back. But yeah, like people want to help animals, and how do we let them do that the best possible is where Recover and the CPR guideline and the certification process is going to be very important. And so one of the biggest pushbacks that I feel like we hear is that CPR has a low success chance anyways, and so why would we want to spend too much resources providing the training? And so to that, I'll give you this quote, that saving one dog will not change the world, but surely for that one dog and their family members, the world will change forever. And so every animal that we can save through better CPR does make a difference. And if this is a patient that had nothing else wrong with them, and it was an anesthetic arrest or something like that, it was an accident that happened, shouldn't we know how to perform CPR? So I'll leave you with that thought, and thanks for listening.